Good morning, everyone. Welcome to day 2 of the 7th Rhode Island All-State IDEA Symposium, which we've held annually now for the last 5 years. My name is Sharon Rounds. I'm a pulmonary critical care physician at the Providence VA Medical Center and co-principal investigator of the Cardiopulmonary Vascular Biology Center of Biomedical Research Excellence based at Ocean State Research Institute. It's my honor and pleasure to moderate the 2020 Rhode Island All-State IDEA Symposium. This symposium celebrates the progress in biomedical research in Rhode Island in the past 19 years, stimulated by the Institutional Development Award program. It also celebrates the collaborations, collegiality, and networking among Rhode Island investigators. It's been the hallmark of Rhode Island IDEA programs. IDEA investigators in Rhode Island from different academic, healthcare, and research institutions are proud to work together. Planning for this event started last fall with a meeting of all of the Rhode Island IDEA PIs who evaluated survey feedback from our 2019 event. A planning committee was appointed and planning commenced for a full-day event with keynote speakers, talks, 4 electronic poster sessions, breakout sessions, and of course a happy hour. Unfortunately, the SARS-2 coronavirus pandemic upended all of these plans and the happy hour disappeared. However, despite this, there was unanimous agreement that the event should still take place, but virtually. So plans were revised to better fit this virtual platform. Yesterday, we enjoyed a terrific half-day program with a keynote speaker, John Sedevy, and an array of outstanding scientific talks from representative project leads from several COBRIs and the INBRI. We have also been pleased to host several program officers from the National Institute of General Medical Sciences and the National Institute of Aging, and we welcome all of our guests and visitors to our event today. Special thanks to the Advance-CTR staff, particularly Oaxaca Schroeder, for outstanding support for our symposium today. Without them, this event would not be occurring. We also thank Brown Media Services for outstanding technical support. Few housekeeping items. Each of the COBRI representatives will introduce the theme of their respective program and also introduce themselves to minimize awkward transitions. Speakers will be sharing their screens to display their PowerPoints. Each talk will be followed by a Q&A opportunity. Please enter your questions into the chat function. It's now my pleasure to introduce our keynote speaker, Dr. Risa Sperling. Dr. Sperling is a neurologist focused on the detection and treatment of Alzheimer's disease at the pre-symptomatic stage. She is a professor of neurology at Harvard Medical School and director of the Alzheimer's Research and Treatment Center at Brigham and Women's Hospital and the Massachusetts General Hospital. She received the MD degree from Harvard and also did neurology postgraduate training at Harvard Medical School. She's now co-principal investigator of the Harvard Aging Brain Study and the NIH-funded Alzheimer Clinical Trial Consortium. Among her many accolades and awards, there's one that I really like, and that is that in 2017, she was named one of the most disruptive women to watch in healthcare. So we're very much looking forward to learning about detection of Alzheimer's at early stages. And thank you so much, Risa, for joining us here today.
Well, thank you so much for having me. I was telling Dr. Rounds earlier that I am very fortunate to be sitting here in occupied Rhode Island, down in Westport, Massachusetts, and it's a real honor to talk to you today in this symposium. So, as mentioned, I'm going to be talking about Alzheimer's disease and trying to detect it at least a decade, hopefully more, before we get to the stage of dementia. So first, let me disclose my relationships with industry, and also I want to acknowledge the funding for a lot of the work I'll be telling you about, much of which has come from the NIA. So I thought I'd punctuate my talk today with a series of Mother Nature analogies, and that's probably particularly appropriate given the storms we had last night. But I'll start with this one, the proverbial tip of the iceberg. And that's because what we recognize as Alzheimer's disease is typically at the symptomatic stages and often at the dementia stage. And as we learn more and more about the pathophysiologic process, we realize that what we can see once people are symptomatic is really just the tip of the iceberg, and that this disease process has begun many years, likely more than a decade, before we can recognize that stage clinically. I also like this analogy because I think as a public health issue, we really need to recognize that all of you who are working on these other areas, trying to keep people alive longer, which is great, you are creating an epidemic of Alzheimer's disease because it is so age-linked, as I'll show you later. And unfortunately, as a society, we are really heading right for this iceberg because many people, unfortunately, are already beginning to develop changes in their brains. So if you took that iceberg and you turned it on its side, it might look something like this. Everyone's got a version of this figure. But when I was training in neurology, we really only recognized Alzheimer's disease at the stage of dementia. And of course, Alzheimer's disease is the most common form of dementia, accounting for, at least contributing to, about 65 or 70% of dementia in people over the age of 60. During the time I was training, people started to recognize an earlier stage, mild cognitive impairment. Now we often refer to this as prodromal Alzheimer's disease, if indeed people have biomarkers or evidence of Alzheimer's disease pathology. And this precedes dementia by approximately 5 to 7 years in many cases. But as I started to work in Alzheimer's disease, beginning, over 20 years ago, I began to realize that even at the stage of MCI, or prodromal Alzheimer's disease, there are already irreversible evidence of neuronal stress and perhaps irreversible neuronal loss at that stage already. And so a lot of the work I'll be talking about today is really trying to move even earlier on this trajectory to a stage that I'll refer to as preclinical Alzheimer's disease. Now, two things. One, I want to say that preclinical does not mean that everybody who's got changes of Alzheimer's disease in their brain will progress down this trajectory and develop mild cognitive impairment and dementia. And also that when I mean preclinical here, what we're saying is these are people who have the hallmark pathologies of Alzheimer's disease, in particular A-beta, amyloid-beta in platform, which I'll show you, as well as neurofibrillary tangles composed of hyperphosphorylated tau. Now, at this stage of preclinical AD, as I'll show you, is quite difficult to differentiate it clinically from what we call normal aging. And you notice I have this normal in quotes because as I get older, there is nothing normal about it. And in fact, age-related changes in cognition and the earliest changes of Alzheimer's disease remain a challenge for us to understand whether, how to best disambiguate these and whether indeed some of them are overlapping. But importantly, the reason to go earlier in the stage of Alzheimer's disease is to do what most other fields of medicine and biomedical research has done well, which is to try to detect disease at a much earlier stage so we can treat it better. And that's really the theme of what I'm going to talk about today. So I suspect that everybody on this webinar has probably seen slides like this, which is the neuropathology of Alzheimer's disease. But I noticed that many of the talks yesterday and today are really focused at a molecular or even submolecular level. So I wanted to disclose, unfortunately, what we can see in living humans, which is at a much grosser level of understanding, at least the way we can detect pathology. So of course, here are the telltale plaques seen at Alzheimer's disease at autopsy. These plaques are extracellular. They are composed primarily of A-beta 1 to 42, but a combination of 1 to 42 and 1 to 40. Here, these dark intraneuronal inclusions occur, so neurofibrillary tangles. These are composed of hyperphosphorylated tau. As you know, if you work in Alzheimer's disease, our field is still fighting almost 40 years later about whether it's the A-beta or the tau. And I hope I'm going to convince you today during this talk that we should stop fighting about this. Both are required for cognitive impairment in Alzheimer's disease. And there's a lot of synergies between these proteinopathies that begin well before there are symptoms. The other important reason to show this slide is that I'm going to be showing you a lot of imaging, molecular PET imaging. And in life, in people, we can only see these proteinopathies in their conformations that are seen in Alzheimer's disease, specifically in plaques. We can only see, or A-beta, we can only see in its fibrillar form, beta-pleated sheets with PET ligands. And tau, at least right now, we can only see in its paired helical form in neurofibrillary tangles. So I live in oligomere land up in Boston. I get to work with Dennis Selko and others, and we're very interested in soluble forms of these proteins, but at least with imaging, we can only see them in their aggregated forms. So about, 18 years ago now, our field really changed when we were able to see these pathologies, again, in their fibrillar forms, at least amyloid, using PET scans. And of course, a bunch of smart folks at Pittsburgh started this by using the same dyes or stains that were used at autopsy and putting on a radioactive ligand, a radioactive tracer onto a ligand so that we could see these during life. So this is data from the Harvard Aging Brain Study, where I'm very honored to co-lead that with Keith Johnson. And we started back over 10 years ago now, and we were very interested in aging. And we looked at amyloid imaging across the spectrum of aging and Alzheimer's disease. And I'm going to demonstrate this to you because this has now been seen by multiple different cohorts. So at the stage of Alzheimer's disease dementia, the majority, but not all, patients we clinically diagnose with Alzheimer's disease have elevated amyloid in a fibrillar form. And most studies suggest that it's about 85% of people who are called clinical AD at the mild dementia have amyloid pathology that we can see with PET imaging or spinal fluid. And that corresponds almost identically to autopsy studies. So we're wrong, even in really good centers like Brown or Brigham and Women's and Mass General. About 15% of the time when we say someone has Alzheimer's disease pathology, they typically have other causes for their dementia. At the stage of mild cognitive impairment, or prodromal AD, if you have A-beta markers, it's about 60% or 65% of people we call clinically MCI have evidence of amyloid pathology in their brains. But what was somewhat surprising was when you look in the CN, which stands for cognitively normal or clinically normal individuals, you see that about a third of clinically normal older people over the age of 65 in this initial sample have evidence of amyloid plaque pathology already. And what you can see here in the imaging is that this, shown here in pink and red, these kind of brighter colors are in this case, PIB ligand binding to fibrillar forms of A-beta. At the stage of Alzheimer's disease dementia, unfortunately, the brain has huge amounts of amyloid. And in fact, most studies suggest that the amyloid level is already plateauing by the time we even get to very mild dementia. And here's a typical, first over here on the far left in blue, the clinically normal individuals who don't have elevated amyloid, that's 67%. But in the middle is a clinically normal individual we would call A beta positive, amyloid positive, or elevated high amyloid. And you can see that the amyloid is accumulating in exactly the same anatomic distribution that we see at stages of Alzheimer's disease dementia, but they're not quite up at that high level yet. So back in 2009, 2010, when this began to be recognized, the question was, well, maybe amyloid has nothing to do with Alzheimer's disease, because how can you be normal and have a head full of amyloid already? So we set out to kind of understand what is the impact of amyloid in the aging brain. So to demonstrate this, I'm going to show you a slide actually from my colleagues down under in the ABLE study. Here in red is the prevalence of clinical AD dementia. This is well known probably to many of you. It's an exponential curve. It doubles by decade. And again, because other people are doing such a good job at keeping people alive longer, unfortunately, this is the epidemic we're seeing because many people are living into their 80s and 90s. Here in green is the compilation of 3 autopsy studies. There have now been about 30 of these, in looking at the prevalence of amyloid plaque pathology at autopsy in clinically normal individuals. So imagine that someone is clinically normal, they came into your clinic or your research study, they were tested that day, and they were hit by a bus on the way after their normal neuropsychological testing. This in green is the likelihood that they have sufficient amyloid pathology to meet neuropath criteria for Alzheimer's disease. And I'll argue that that green curve here is a very similar shape to that red curve. It's just translated back a decade or so, more than a decade. Here in blue is the likelihood of having elevated amyloid at any one of these ages. And now we've seen, as we have more and more autopsy studies, that amyloid imaging is a very sensitive way to detect amyloid pathology in the brain. So if we see a PET scan that suggests there's amyloid there, it's greater than 99% likelihood that there is amyloid there. And if we don't see much amyloid, it's about 97% likelihood that there's not sufficient amyloid plaque pathology. But what we don't yet know is if these blue dots, these people who are clinically normal, have elevated amyloid, will progress to develop AD dementia. And certainly not all of them will. Some will die of something else before they have a chance to. And we are very interested in the factors that promote resilience versus vulnerability to progression. Thus far, it looks though that these blue dots, it takes about 15 to 18 years until they would progress over to develop clinical dementia. For me, this is a glass half full. We potentially have 15 years to try to intervene and prevent these blue dots from turning into red diamonds and developing the symptoms of Alzheimer's disease. So what I'm going to do now is show you a little bit of the data following these individuals longitudinally. So here's data again from the Harvard Aging Brain Study. In blue are older individuals who did not have much amyloid or any amyloid at the time. They came into the Harvard Aging Brain Study. Everybody in this study is normal, and in fact, many of them are super normals. They had to have a very normal score on cognitive testing and be functionally normal. So in the blue are people with low amyloid, and in red are people with high amyloid. And here's what happened even just over the first 5 years we've been following these individuals. Those who had low amyloid, we test them every year, and lo and behold, over the course of 5 to 6 years, most of them who don't have elevated amyloid get better over time. This is a practice effect and an important sign that your brain is working well because you're learning over time. Unfortunately, those individuals, in this case, it was about 28% of the individuals in the Harvard Aging Brain Study at baseline who had elevated amyloid, they demonstrated decline over time. This is the preclinical Alzheimer's disease cognitive composite. I'll come back to this when I talk about prevention trials. because we use this as an outcome now in our clinical trials. For those of you who are interested in different domains of cognition, one of the other surprises was I always thought of Alzheimer's disease clinically as really a memory disorder, and it certainly does affect memory. But in early stages, amyloid is also related to changes in executive function and even speed of processing that we've often referred to as normal aging. But you can see that this is actually related to amyloid. So something like the digit symbol shows an amyloid related decline, and even the mini metal status examination, which is a very insensitive screening test, shows a decrease over time in those people who are elevated amyloid. But it is the case that memory tests in particular are sensitive to amyloid, and as I'll show you later, tau markers and decline most precipitously during these preclinical stages of Alzheimer's disease. So this is data from ADNI, the Alzheimer's Disease Neuroimaging Initiative. I think actually there are 2 sites in Rhode Island, Brown and University of Rhode Island are both part of ADNI. And this is a multi-center study of about 50 sites where people were characterized on the basis of their amyloid status. They started out using spinal fluid and added amyloid imaging later. So these are individuals who had either spinal fluid or PET in the beginning. But you see a very similar pattern. So over the first couple of years, actually, the low amyloid group get a little bit better. But after about 2 to 3 years, you can see this elevated amyloid group begin to decline. And this decline accelerates substantially over the course of time. And ADNI now has data out to 10 years. And over here is evidence looking at the clinical dementia rating sum of boxes, CDR. You can see this is a functional scale looking at whether people are progressing towards functional impairment. This takes longer, typically it takes 4 or 5 years to start to see real changes in clinical daily function. But you can still see this exponential curve start to take off at about 4 to 5 years as these individuals approach impairment. Yeah. Let's see if it'll let me advance still. No. There we go. One of the other things that we've been very interested in is trying to understand what are the factors that actually promote faster, more rapid cognitive decline or promote resilience. And it's been known for a long time, of course, that APOE4, and I'll show you some more data on this later, is a significant risk factor for decline and the likelihood of developing Alzheimer's disease dementia. It's also been shown in our studies and many others, individuals who are looking at clinically normal individuals with amyloid imaging or spinal fluid, that amyloid levels are much higher in people who carry an APOE4 allele. But what is quite interesting is that we can see that there's an interaction between APOE and sex. This is also, again, the first APOE studies way back in, I think, in 1990 or maybe even before this, suggested that the APOE effect was seen much more in women. It's also been suggested that women are almost 2 times as likely as men to develop Alzheimer's disease dementia. And this is partly because we women live longer, but it also appears to be because if we are unfortunate enough to have an APOE4 allele, that females are more vulnerable in the setting of having that genetic risk factor. And what you can see here is that it really is these female APOE4 carriers who are driving that substantial decline we see in people who have elevated amyloid. The good news is if you're an E4 carrier and you don't have amyloid, you're an escapee. About 30% of E4 carriers do not have amyloid, at least at this age. You're relatively protected. But if you have high amyloid, you're an E4 carrier, and unfortunately you are also a woman, your risk of decline is quite substantial. So far I've really only been talking about amyloid. And I think one of the real advances in our field is now about 6 or 7 years ago, we started to be able to see the other hallmark pathology of Alzheimer's disease, which is tau. And again, we can only see tau here in its paired helical filament form, again, using a tracer. This is T807, now called fludarabine, which actually was recently just approved by the FDA. And we started these studies, again, trying to understand whether it's amyloid or tau that seems to be important for decline. At the stage, again, of Alzheimer's disease dementia, people not only have a head full of amyloid, they already have a head full of tau. So this is a person with an MMSE of 25. You can already see that there's very substantial tau pathology throughout the cortex, particularly in the temporal lobes, but already up into parietal and frontal cortices as well. The good news is most of the low amyloid or amyloid negative normals also don't have much tau. Tau seems to be restricted to the medial temporal lobe, which is known to be age related. But this group in the middle, again, who has elevated amyloid, even though they're still clinically normal, we started to see evidence that they have tau that is now not only expanding in the medial temporal lobe, but beginning to spread out into the surrounding cortex in a pattern that is very similar to what has been reported in later stages of Alzheimer's dementia. And we started looking at these individuals. So we started tau imaging in about 2014 in the Harvard Aging Brain Study, but then we're able to look prospectively over the next 2 to 3 years. And we could see that the majority of these individuals who were having very imminent cognitive decline, and here in these green triangles, progressing to the stage of MCI within 2 years of having their PET scan, even though they were clinically normal at the start of this portion of the study, is driven by those who have high amyloid and high tau. It's a small number of these individuals, again, because they all had to start out normal, but it appears in this data and now multiple other data sets that you need both elevated amyloid and elevated tau, particularly as it's progressing out into the rest of the cortex to drive this rapid decline and progression to clinical impairment. So this leads to my second Mother Nature analogy, which is that of a forest fire. So one of the things that we're very interested in is how do amyloid and tau relate in terms of their progression. And there's at least some question as to whether amyloid somehow facilitates or can accelerate tau spreading. There's some beautiful data on this from mouse models, but also we now are starting to see this in humans. So here is, this is data from Keith Johnson in the Harvard Aging Brain studies. For full disclosure, is also my husband, fortunately for me. And one of the things that he's been interested in a long time is this acceleration of tau accumulation. So I want to show you two things. Here's cross-sectional HABS data, and this includes people who are normal as well as people who have progressed now to mild cognitive impairment, a few with dementia. And you can see here in red in particular, these individuals who are elevated amyloid, that we no longer just see a linear curve, that this is exponential. And that once you get to a certain level of amyloid, at least cross-sectionally, it looks like you have more tau than you would expect for a certain amount of amyloid. And again, this curve starts to look very similar to the cognitive impairment curve when we follow people longitudinally. And this over here on the right is longitudinal data from HABS. These individuals in blue are those who are clinically normal. Those in red are people who progressed to MCI after having their tau scan. And again, you can see this elevation of tau, very rapid increase in tau in these majority of individuals who have MCI. We refer to this as the catastrophe in our group because we like bad tau jokes. But this is very, very relevant to what's happening in clinical trials right now, because this suggests that there's probably a stage once you get beyond this of amyloidosis that amyloid may be less influencing tau. And at that point, tau becomes potentially relatively independent and takes off. And I think this is critically important for thinking about the stage of Alzheimer's disease we need to treat, at least particularly with anti-amyloid therapies. So I've been talking primarily about A-beta and tau, but of course we know that vascular risk is particularly important from both epidemiologic studies and autopsy studies, that the majority of people with dementia don't have pure Alzheimer's disease. They very commonly have vascular pathology. Vascular dementia itself, isolated, is very rare, but it's very common that people have both AD pathology and vascular pathology, particularly in people over the age of 65. So here we looked at whether vascular risk, just using a Framingham heart score, actually modulated change in individuals who were clinically normal at the start of the study. And what we can see in the PAC decline here is that people of low cardiovascular risk, even if they have elevated amyloid, don't really change much. And it is this group who has both elevated amyloid and evidence of a higher cardiovascular risk on the Framingham heart score who are declining the fastest. And very interestingly, from my point of view, is that this actually drives tau. So I always thought kind of Alzheimer's disease is over here and vascular disease is over here, and they're two pathologies, and it's comorbidities, and they just happen to have two hits. But this data suggests that people with elevated amyloid and have vascular risk actually increase their tau accumulation at a faster rate. And so it may be that vascular pathology actually interacts with A-beta in making the downstream consequences of A-beta occur more rapidly, and in particular, neurofibrillary tangles, which are more strongly associated with cognitive impairment. There we go. All right. So this is my mother nature picture trying to show resilience. And so far, I've really been talking mostly about doom and gloom. You have these proteinopathies, especially if you have vascular risk as well, and your likelihood of developing dementia goes way up. But I actually do believe that we can do something to make our brains more resilient. And one of the things we can do certainly is exercise. This is some data that we published early last year, which is looking again in the Harvard Aging Brain study in individuals who had elevated amyloid or not elevated amyloid. And we gave them pedometers, which they wore for a week. And then we looked at what happened to them over the next 5 to 6 years. And what you can see is the individuals who have low physical activity, if they also had elevated amyloid, again, had a significant risk of decline. But somewhat reassuringly, the individuals who had elevated amyloid, if they had higher physical activity, again, this is 5 to 8 years prior, with just 1 week of pedometer data, they had lower rates of decline. And this, it looked like it took about 8,900 steps per day to be protective. So that 10,000 steps per day that people have been talking about for years and years probably is about right in terms of being able to be protective, at least for early Alzheimer's pathology. And down here, these brain images, these are regions of the brain showing greater rates of atrophy or differential rates of atrophy, depending on whether people had significant physical activity measured by a pedometer. And these areas of the brain shown here in yellow showed faster rates of atrophy in those who had lower physical activity if they also had high amyloid. So again, evidence that we can make our brain potentially more resilient to the effects of amyloid and neurodegeneration by getting it out there, which I know is particularly hard to do in these times of COVID. So at this point in the talk, people are inevitably wondering, well, why would you possibly want to know or tell someone that they're at increased risk for developing Alzheimer's disease dementia in a decade or two if there's nothing you can do about it? So I want to spend the rest of my talk trying to argue that this is the way we're going to do something about it, just like we have in every other field of medicine, by detecting disease at a much earlier stage before there's irreversible damage and trying to prevent the progression. So this is the case for earlier intervention. Our field in Alzheimer's disease, unfortunately, does not have a great track record. There have been 13 phase 3 trial failures at the stage of symptomatic Alzheimer's disease over just the past decade or so. And I have a little asterisk here because, of course, there are some additional analyses going on from one of the recent phase 3 trials, and we'll see whether that yields some more promising results. Most of these trials that have failed at symptomatic AD are at the anti-amyloid approaches. And this you have to take very seriously because we've had multiple trials now that have failed. However, as I showed you, by the time people have dementia, they not just have a head full of amyloid, they have a head full of tau, and they've had this pathology for more than a decade. And we already know that there's substantial neuronal damage and loss already at the stage of dementia. So I think at least if we're going with anti-amyloid therapies, we need to be going much earlier. There's huge public health reasons to intervene much earlier. We actually don't have to cure Alzheimer's disease. We just have to delay the dementia phase by about 5 years. And it's estimated by the Alzheimer's Association that that would reduce projected Medicare costs for dementia by nearly 50%. And that's, of course, because the expensive stage of Alzheimer's disease is at the later stages when people need care. And I always like to say that if we can delay this dementia by 5 years, people will die out ballroom dancing instead of in nursing homes. And I know all of us want to die ballroom dancing, especially all the guys out there. And this seems like it's somewhat heretical in Alzheimer's disease, but this is exactly what the strategy that's worked in all of the other fields where I really feel like we've made progress. Think about cancer, stroke, HIV, diabetes, osteoporosis. And what happens if we wait for someone to walk into our office with symptoms of these diseases versus detecting disease with blood tests, with scans, other screening, and being able to intervene before they get to a stage of irreversible damage. So this leads to the idea of trying to treat people with the right drug at the right stage of Alzheimer's disease. What we've seen in the past decade is a shift from dementia back towards MCI. I'll still refer to this as tertiary prevention and treatment, but the at least somewhat promising results that have come out of phase 2 and potentially phase 3 studies, I think are one, because we've gotten more aggressive with our anti-amyloid therapies, but especially because we've already moved 5 to 7 years earlier in the treatment back to a stage of prodromal Alzheimer's disease where there's less irreversible neuronal damage. We all want primary prevention. We want something that's safe enough to put in the drinking water of everybody over the age of 18 or maybe even in utero. But you know, those 75-year trial designs, very difficult to get funded even by NIH. And of course, we don't have drugs that are safe enough and known to be efficacious enough to go to primary prevention yet. So most of us have focused our efforts on what I'll call secondary prevention right now. And here, by secondary prevention, we mean finding individuals who have evidence of the disease in their brains, but they don't yet have the clinical syndrome. And our job is to try to prevent the further progression of the pathology in the brain and prevent or at least delay the onset of the clinical syndrome. And this has been a really exciting time over the past few years as multiple secondary prevention trials have launched. So I'm going to spend time talking primarily about the A4 study because I have the honor of leading this. And the approach here is to find these clinically normal individuals who have evidence of elevated amyloid but don't yet have any symptoms of Alzheimer's disease. This is a phase 3 trial, a randomized, typical double-blind, placebo-controlled trial. It's a long trial, 4.5 years, so we can see the changes in these people over time. It has 67 sites in the US, Canada, Japan, and Australia. Again, 2 sites in Rhode Island, Brown and University of Rhode Island, both fabulous sites. And our original enrollment goal was 1,150. We stratified by APOE. We also follow a group of individuals who screen failed for the A4 study because they didn't have elevated amyloid in the LEARN study funded by the Alzheimer's Association. And importantly, I won't talk much about this, but I'm happy to answer questions. We also study the disclosure of amyloid status to our participants, because if this or other trials succeed, we really need to understand how we disclose this information safely and, importantly, telling people what we don't yet know about individual risk related to amyloid. So I'm just going to demonstrate the idea of the A4 study. So again, here's this hypothetical high amyloid curve versus a low amyloid curve. And what we're trying to do here with early intervention is to bend this amyloid positive curve back up towards this amyloid negative curve, because if we can do this early enough, we can really change cognitive outcomes, we hope. The A4 study is powered to see about a 30% bending of this curve back up towards the amyloid negative over 4.5 years. And it's estimated that if we can bend that curve by 30% over that 4.5 years, we could prevent up to 50% of cases of dementia at that time frame. So let me show you some early results from that A4 screening data. We've made all of these data publicly available now. So you're welcome to download them online from Loney. The first results of this now are coming out in papers, and I'll show you some of this data. So we telephone or web screened about 15,000 individuals who were interested in the study, and we had in-person screening visits about 6,763 individuals. Of those, 4,486 were eligible to go on and have amyloid PET screening. Now, based on our other data from HABS and ADNI and many other places, we estimated that 30% of those who met these criteria who underwent PET screening would show elevated amyloid, and the results were 29.5%. So that prediction was really very close to what we had predicted. Those individuals with elevated amyloid were eligible to continue in screening, get MRIs and other things, and ultimately randomize into the A4 study. And we had to close screening in December of 2017 because we exceeded our enrollment goals and randomized 1,169. Those who didn't have elevated amyloid, again, were eligible to go into LEARN study, and they're followed longitudinally with all of the same outcome measures. So here are some of the data from the screening data demographics. I'm comparing now those who are not elevated on screening PET for those who are elevated. Not surprisingly, the elevated group was slightly older, only about a year. And I'm demonstrating here the power we have with these kinds of numbers to see even very small effects, because this will be relevant when I show you things that don't show significant changes or significant differences between the groups. So one of the ones that didn't is education. So we know that education may be protective from getting a diagnosis of Alzheimer's disease dementia, but it looks like what education does is just allow you to hide your amyloid or your tau pathology for a longer time. And it does not appear to be protective, at least from amyloid pathology. I showed you before that women have an increased risk of decline, particularly if they're E4 carriers. Women are known to have an increased risk of Alzheimer's dementia, but they don't show higher levels of amyloid. And in later studies, it appears that the higher risk in women is primarily due to tau. That for a given amount of amyloid, they have more tau. The risk of amyloidosis is not higher in women. And in marital status, I was disappointed to see this because we recently celebrated our 30th wedding anniversary, but staying married actually has no effect on your amyloidosis, although being widowed or divorced has a risk for cognitive decline, particularly among women. Retirement. It's been known for a long time that people who retired early are more likely to develop dementia. But again, this is probably related to resilience to amyloid pathology because no difference in amyloid. And here is the, for those who follow amyloid imaging, the difference in PET values. So by definition, not elevated is right at 1. So these people really are that same ratio as we can see in the reference tissue. But the elevated amyloid group has what's called an SUVR of 1.33. And this is about a third of the way up the curve in this PET tracer to the maximum amyloid level we see at the stage of late dementia. So these people have substantial amyloid, but they're still relatively early in their rise up. So I mentioned APOE4 previously. Here is data from the A4 study. in screening. First of all, family history. Overall, it was about 72% of people who came into the study reported having at least one first-degree relative who had dementia before the age of 80. That's probably not surprising. It's much higher than you would see typically in a study of just older people, but people who've seen Alzheimer's disease up close and personal are, of course, more likely to come in and screen for this trial. But the family history was higher in individuals who turned out to be elevated amyloid, and that's largely because of APOE4. We know that in the stage of dementia in the clinic that about 60% of Alzheimer's disease patients carry an APOE4 allele. And here we saw that 58% of people with elevated amyloid who were still clinically normal carried an APOE4 allele. And this was very reassuring to us that in fact we are enrolling a population who is very similar to those who will likely get Alzheimer's disease dementia later. Similarly, APOE4 is again a risk factor. APOE2 and especially 2,3 and even 2,4 decrease the likelihood of having elevated amyloid. Now, this was somewhat of a surprise. So I'm, as I mentioned, very interested in resilience and lifestyle factors, and there had been some early reports that lifestyle might be protective. And again, I think it is protective against cognitive decline, but we did not see any evidence that lifestyle habits were protective against getting amyloidosis. And now a few other studies have replicated this as well. So even though I am a strong proponent of aerobic exercise, it probably protects your brain against vulnerability to tau and to downstream consequences, but it really does not appear to protect you against amyloid. Neither, the only one that got even close at a trend level was sleep. And there's some very interesting work that sleeping more, especially slow wave sleep, might reduce amyloid. But most of these lifestyle issues really had no effect on amyloid. I do believe they may have an effect on long-term decline and tau and neurodegeneration, but likely, unfortunately, amyloid is driven primarily by genetics. So the other thing that was a bit of a surprise is that although you can see over time that people who are normal but have elevated amyloid decline over 5 to 10 years, typically at baseline, cross-sectionally, we don't see differences because, of course, they're screened to be clinically normal. They have to all perform in a very narrow range of normal cognition. But when you've got huge numbers like this, 4,000 people, you can see even very subtle effects. And at screening, we did the cognitive testing at the first visit, which is about a month before people got their PET scan and were told whether or not they had elevated amyloid. But we could see that that testing, even a month before anyone knew if they were even going to be eligible for a PET scan, that those people who had elevated amyloid had lower performance on the PAC. Not only did they have lower performance on the overall composite, but they had it in almost every one of the components. So the MMSE, once you adjust for age, sex, and education, drops to a trend level. But here, these executive function tests, and particularly these two memory tests, again, these are done a month before the PET scan, people who have elevated amyloid already perform less well, even in this very narrow range of cognition. We also here started to, besides using standard pencil and paper tests, we use an iPad test, which we're now porting to a smartphone, where we can look at more sensitive potential measures among normal individuals, using card playing tests from Cogstate, a face name memory test that my colleagues and I have been working on for a while, and a pattern separation test, which is a particular hippocampal task. And we can see that this computerized testing, again, also done a month before the PET scan, also shows that the elevated amyloid group performed less well. And very excitingly for future trials, this computerized testing has almost the same Cohen's d as we see in this half-hour-long standardized testing. We also assess neuropsychiatric variables. One of the questions has been about depression, the GDS, Geriatric Depression Scale. Here we see only a trend level at baseline. We have seen greater rates of depression longitudinally associated with amyloid, but anxiety was actually significantly higher in those who had amyloid. And again, this testing was done a month before we did the PET scan. So this early anxiety that's been presented that might be associated with very early changes in Alzheimer's disease is associated with amyloid, even in clinically normal people. Now, when I was training in neurology, I was always taught that if someone comes in complaining about their memory, saying that they're worried about their memory, they're forgetting things, you can pat them on the head, tell them they don't have Alzheimer's disease, and send them on their way. But increasingly over the past decade, as we've been able to look at biomarkers in these people who are still functioning normally, we can see that in fact, when somebody's really worried, when they say they have really changed in their ability to do cognitively demanding activities of daily living, unfortunately, they are more likely to have amyloid and subsequently decline. So this is something called the Cognitive Function Index, simple 15-item question where you ask, have you had changes in your memory, changes in your ability to do high-level activities like plan trips, use a smartphone, do Zoom meetings, but other cognitively demanding activities. And this questionnaire is also given about a month before the PET scan. And what we can see here in the participant, the self-report, that people who were found subsequently to have elevated amyloid reported that they were more likely to have a change, a decline in their cognitive function over the past year. Even though all these people are still normal, but if they had elevated amyloid, they were more likely to say either maybe or yes, that they had had changes on some of these areas of cognitive and memory function. The study partner report typically is less sensitive because, of course, they have to say the person's normal for them to be eligible for the A4 study. You can even see a little bit of a difference here, and I'll show you which questions they said. And this is an important outcome in these prevention trials because now we're not just looking at very sensitive cognitive tests, we're looking at what matters to people. Can they live independently doing these high-level activities of daily living? And here we see evidence that amyloid is associated with very subtle changes, again, years before people even get to mild cognitive impairment. So here's the things, types of questions we asked people. Asked if they'd had substantial memory change, if they had been misplacing things, disorientation with traveling. Many of these things, both the self and the study partner reported. Interestingly, and this has been seen, I know, in Brian Ott's work as well, that people sometimes have subtle changes in trouble driving, getting a little lost, or even some fender benders. But the study partner was more likely to say that the participant who had elevated amyloid had trouble following the news and repeated questions. So those of you who've seen patients, unfortunately, with Alzheimer's disease in the clinic or family members know that this is one of the hallmark symptoms, that people ask the same question again and again and don't realize that it's been answered. And here the study partner reported that in people who subsequently were found to have elevated amyloid a month later, suggesting that, again, these symptoms begin much earlier than we realized. And finally, here I want to show you a little bit of the tau PET imaging. We added tau PET at the end of, in the middle of our A4 recruitment because tau PET didn't exist when we were first starting the study. But here is a map showing you among the A4 about 400 people who had tau PET imaging. Areas of the brain where more amyloid is associated with more tau. Even though all of these people are clinically normal, all of them have elevated amyloid, you can still see that amyloid is related to tau at this preclinical stage, including in the medial temporal lobe and the entorhinal cortex that we often think of as normal aging tau, but it is related to how much amyloid is in the brain. And it's also related to performance on the PAC, and particularly in the memory measures. There are independent effects of amyloid and tau on cognition in these 400 individuals. And here is the map of where tau, particularly in the medial temporal lobe and temporal cortices, is related to cognition, even in the range of normal and even in all elevated amyloid individuals. So in my final couple minutes here, because I want to give time for questions, I want to say, how do we push even earlier in the Alzheimer's continuum? So I've told you that A-beta accumulates more than a decade, probably close to 2 decades prior to dementia. And once you start to accumulate, there's no going back. We can see subtle cognitive decline associated with early amyloid and tau accumulation years before people are impaired. More than half of the elevated amyloid positive individuals in A4 already have elevated tau in their neocortex. And once both amyloid and tau are clearly elevated, people decline rapidly, typically within 2 to 3 years. So why would we wait for that stage to intervene? Here's some longitudinal data from the Harvard Aging Brain Study. In red are the E4 carriers, and black are the non-carriers. What you can see is once you have elevated amyloid, here at about 1.2, once you're past that threshold, there's only one way. Everyone is going up. And at every age, you can see people moving from this amyloid negative or low amyloid group up into the elevated amyloid. The red are earlier. E4 carriers accumulate earlier, but they accumulate at the same rate once they start to accumulate. And these people who are E4 carriers already elevated at age 65 or 70, they started to accumulate way back here, probably at age 55. So that led to us trying to understand how early can we actually look at these changes. This is a complicated mediation model published by Bernard Hansu and Keith Johnson in our group. But the important things here are that this early initial amyloid level drives amyloid change. So even this subthreshold or low amyloid level is a good predictor of whether you will accumulate in the future. The more amyloid increase you have, the more tau increase you have, and that is what's really related to final cognitive outcomes. And we started to look to say that we could see this very early increase in amyloid, even in those people who are not elevated amyloid yet. This is data across ADNI and ABLE and Mayo Clinic. And you can see this very rapid increase in the rate of accumulation. And I think that's actually where we want to intervene. So in the AHEAD study, which will be starting in July, in the A3 portion, we're going even earlier. We're going down to age 55. And here we're taking people who have intermediate or lower levels of amyloid and trying to prevent them from accumulating. And the primary outcome is A-beta amyloid change and tau. In the A4-5 study, we're taking people who already have very elevated amyloid, looking again at A-beta and tau being more aggressive with antibody treatment and trying to prevent them from showing cognitive decline. This study, as I said, will go down to age 55, particularly in the younger group will require additional risk factors such as genetic or family history. And in these individuals, we'll study them for 4 years again. We'll be using both amyloid and tau PET, but now rather than using solanezumab, which is an antibody against soluble A-beta, we'll be using a plaque-clearing antibody, particularly in this A4-5 group, to be more aggressive at knocking down plaque with band 2401. And again, we'll start this July. So this all may sound crazy to you, but hopefully not to Dr. Rounds and others who remember the cholesterol wars in cardiology, where people had fights in the 50s and 60s and 70s about whether we could even measure cholesterol, whether it had anything to do with heart disease. But by doing secondary prevention trials in familiar hypercholesterolemia and in sporadic heart disease, especially in people who had a MI or angina heart disease, but still had good heart function. And intervening at that stage is estimated to have reduced cardiac morbidity and mortality by 28%. My cardiology colleagues always complain, well, cholesterol is only 28%. Imagine if we could reduce dementia by 28% in Alzheimer's disease. Amyloid doesn't have to be the only factor. I'm sure it's not. It's one piece of the puzzle, but at the right time, it might be critical. And as in A3, we now treat people with very low levels of cholesterol. We don't treat a cholesterol of 300 or 250 or 200. We go now on LDL and treat people sometimes even with normal LDLs if they have risk factors. Once people are symptomatic, I think amyloid alone will not be enough, especially if they have dementia, maybe at the stage of MCI. We're going to need combination therapy. We're going to have to be aggressive, just like we are in cancer and heart disease, because AD is a formidable opponent. So my last Mother Nature analogy, of course, is that of a tsunami. But I've come to realize that a tsunami is not a good analogy for Alzheimer's disease, because a tsunami is once in a lifetime wave. And unfortunately, Alzheimer's disease is wave after wave after wave facing our healthcare system and older people. So we're going to have to get a lot more aggressive and give these people something in the lifeboat. So I'll end by acknowledging the terrific group of people I get to work with here in Boston, all of the sites and the fantastic participants and their study partners in A4 and these other studies. And thank you so much for your attention virtually today. And I greatly hope you'll ask me some questions. Thank you.
Fantastic. Thank you very, very much. So, bravo. So we have a lot of questions.
Oh, good. I'm thrilled.
Here's one from me.
Okay.
So should the worried well, age 65 or over, get routine PET scans?
No. I think at this moment, certainly not, because we don't yet know what to do with that information in terms of treating you. I think this will change if A4 or any of these other prevention trials are successful. But the good news is that I don't think we'll have to be doing PET scans at that point. I didn't put in slides about this because it's early data, but there are now blood tests that are pretty well correlated with PET scans. And by the time we have a therapy that is disease modifying, I think we'll have less expensive ways to screen. And I do imagine people getting blood tests every few years for amyloid and potentially tau, probably beginning at the age of 60 in a decade from now.
So that relates to a question, is there a well-defined blood test for the proteinopathy in the early stages? And what are these blood tests measuring?
Right. So there are, actually, this is a very hot area of research. Most of the tests so far are measuring species of A beta, and most of them look at ratios of A beta 1 to 42 to 40 and other ratios, also 38. And two of the most promising approaches actually use mass spec to do this. You can get really sensitive. Those, whether we can scale those up to use in widespread screening, we'll see. And there are immunoassays that are also being developed. These, again, correlate pretty well with amyloid doses, and I think in our next trial, we will be at least an exploratory way using these blood tests. And very exciting, just in the past couple months, better assays for tau, phospho-tau, have come out. And just as I showed you with PET imaging, you need both amyloid and tau to really predict decline. I think that will be true of blood tests as well.
Fantastic. Are there cognitive tests outside of the clinical setting available for folks who might be concerned about cognitive decline?
Yeah, so there are tests, there are a lot of things out there, but I think they're not super well validated yet. And that's actually one of the things a lot of people in my group and others are working on, because we have lots of tests that can tell you when you're not doing well, but we don't yet know how specific they are and how predictive they are of future. And that's one of the things we can do with these biomarkers is validate some of these tests. But there are, actually, we're working a lot on a smartphone app that people might be able to take once a year. So you get a blood pressure and you get your, cognition tested in the waiting room.
What would other human biomarkers aside from amyloid and tau be useful? If so, what specific molecules or pathways do you think would be most helpful for tracking dementia in humans and for improving clinical trials?
Absolutely. So one of the hottest areas of interest is inflammation. The interesting thing there is that it cuts both ways. So early on in the disease, actually inflammatory markers going up may be a positive sign. So that's been confusing because we think of inflammation, blood markers of inflammation as being a bad thing, but they are actually associated with being able to clear these proteins early in the brain, and they may be good. But at later stages, it's pretty clear that inflammation is a marker of trimming off synapses and probably predicts neurodegeneration. So I think that's a very hot area, but right now there's not a simple answer to that because the markers change over time. Also, synaptic markers, we can't see them yet well in blood, but it would be incredibly helpful. Maybe exosomes will help us, because I can show you all the A beta and tau I want. What I really want to know is, are the neurons working as well as they should? And so having a synaptic marker in blood would be awesome.
What's the role of increased blood-brain barrier permeability in tau or amyloid accumulation in the brain?
Yeah, so I think
Might
this is
this
also,
be a marker?
right, exactly. So I think this is also still an area of research. It is the case at the stage of dementia, there is definitely some breakdown of the blood-brain barrier, but it's not clear that that's the earliest change. So I think it may be that we don't have sensitive markers of blood-brain barrier, but when we see it, say, with gadolinium in humans or even in animal models, that's a relatively late stage change, and I imagine there are things happening earlier and we just don't have good ways of detecting it yet.
Okay, how does amyloid beta facilitate the spread of tau?
Now that is definitely the $60 trillion question. So I have to say that I don't think we know. One idea, though, that I guess this would be my best guess, is that it's not really specific to A beta. It's that you have protein machinery that is getting gunked up as we get older. So our ability to kind of chaperone, handle proteins, take them through the normal degradation pathways changes as we get older. A beta is the most rapidly turned over protein in the brain. And once you start to accumulate that, that's a good marker that your protein machinery degradation has failed. And it may not be specific at all to A beta, but it's just a lot of it. And once you have that problem, then you can't turn over tau, TDP-43, alpha-synuclein. All of these proteins start to accumulate in the brain. But there are some people who think it's something specific about the stickiness of A beta, that if you seed A beta, you can cause tau spreading. This is mostly animal data, not humans. So it may be that tau is also an amyloid. It's something about these proteins and how they form conformations that really might be important, but no one's proven that yet.
Okay, fantastic. Well, our time is up. Bravo, thank you so much. Very stimulating and thought-provoking talk, and gets us kick-started for the rest of our program. So thank you so much, Dr. Sperling.
Well, thank you for having me.
Our next speaker is Molly Monig. She's on the faculty of the Brown School of Public Health, and she is representing the COBRE for addiction and disease risk exacerbation. Molly.
Hello. That's right, I'm Molly Monig. I'm a project leader at the Center for Addiction and Disease Risk Exacerbation, which is an NIGMS-funded center of biomedical research excellence in Brown School of Public Health. I have no disclosures. The overarching goal of our center is to investigate mechanisms by which substance use increases risk for or exacerbates chronic disease. And this builds on a wealth of research, observational research showing high comorbidities with substance use and chronic disease. And our work really looks to take that one step further by identifying causal mechanisms and pathways. And in doing so, we emphasize mechanistic laboratory work. Our center is committed to diversity and inclusion and to eliminating health disparities. And we investigate a broad array of substances of abuse, including nicotine, alcohol, opioids, cannabis, and others. And our cadre promotes synergy across projects by using shared measures and biomarkers that are coordinated by our clinical laboratory core. Here's an overview of our leadership and structure. And I'll just highlight our director, Peter Monti, our deputy director, Jasjit Alwaya, and our clinical laboratory core director, Jennifer Tidy. So the topic of my talk today will be the pro-inflammatory effects of acute alcohol intake on the gut-brain axis in people living with HIV infection. I'm an assistant professor of behavioral and social sciences, and my background is clinical psychology. And my research background is in using magnetic resonance imaging to study brain behavior relationships in alcohol use and particularly in heavy drinking. And the support of the cadre, as well as a K23 award from NIAAA, has allowed me to develop a focus on alcohol use in the context of chronic disease, specifically HIV infection. So I'd like to take a moment to thank my mentors, collaborators, and research teams on those projects. As a quick outline, I will start with background on alcohol use in the context of HIV infection, present some preliminary data about alcohol's effects on healthy individuals and people living with HIV, describe my current study that I just am beginning on acute neural and inflammatory effects of alcohol in people living with HIV, and then have a few moments for your questions. So starting with background, alcohol use is a significant factor, lifestyle factor in people living with HIV, with over 50% of this population using alcohol on a regular basis. And about 16% of people living with HIV report binge drinking in the past month. Alcohol use at any level in this population is important because just one drink per day is associated with increased risk of mortality and injury. And that's work by Amy Justice and her colleagues at Yale. So again, the mechanisms behind this association aren't yet known, but my interest and my focus is on the gut-brain axis. So although we think of alcohol and HIV as very disparate influences, one being a chemical, one being a virus, we actually see some similar or parallel effects. So both alcohol and HIV cause gut dysbiosis and deplete gut lymphocytes, and also cause intestinal hyperpermeability. And these factors together cause microbial translocation, which is the movement of gut bacteria from where it belongs in the gut to where it does not belong in systemic circulation. And this, in turn, is a very pro-inflammatory stimulus. Alcohol, for its part, is a modulator of peripheral immune activity. It can be stimulatory or suppressive depending on dose and timing, which I'll say more about in the context of this presentation. HIV infection, for its part, is more pro-inflammatory across the board. Alcohol and HIV both cause neuroinflammation, and it's important to say that when we observe these more harmful effects of alcohol, it's usually heavier chronic alcohol at play, not moderate alcohol, but that's in healthy individuals without underlying health conditions, and really the threshold effect or level of or safe doses in people living with HIV are not known. So here's just a diagram of the working model here. So we see alcohol and HIV, the independent effects that I talked about on all of these processes previously, and then the synergistic effects that I proposed to study on the gut-brain axis. And I would also just note that these processes are not independent. So microbial translocation from the GI tract promotes systemic inflammation, which in turn can promote neuroinflammation through signaling across the blood-brain barrier and other mechanisms. That leads to my primary research question: does alcohol use exacerbate inflammation along the gut-brain axis in the context of HIV infection? So for some preliminary data, I'd like to talk about I'll start with a little bit of background on the biomarkers that we use for these processes. Lipopolysaccharide is a widely used marker of microbial translocation. LPS binding protein, or LBP, is a marker of immune response to LPS. Soluble CD14 is a marker of monocyte activation to LPS and other ligands. And we have a host of others that we look at, and then I'm looking at my current project that I'll spend less time on today because my preliminary data is on these first three. We see that for alcohol, there's a bit of a mixed bag in terms of increase-decrease in previous literature. There's a bit of a biphasic response. And this asterisk here really is kind of a reminder to me to say that it really depends on the dose and the timing. So is it heavy binge alcohol? Is it moderate alcohol? Are you measuring directly after administration versus 4, 5, 6 hours later? For chronic alcohol and HIV, we see more parallel effects where both across the board have increases. So looking at acute alcohol effects on biomarkers and microbial translocation in healthy individuals in a small pilot study that I conducted with support from the, from the different COBRI led by Dr. Sains at the Brown's Department of Neuroscience. We saw actually these biphasic effects in LPS where it was an overall decrease, but an initial increase, and then kind of mirrored effects in these acute phase proteins where we saw initial decrease followed by a significant increase. So this is moderate alcohol. So we gave people moderate alcohol after drawing their blood at baseline, then measured these markers 1, 2, 3 hours later. And then in terms of chronic effects of alcohol on these biomarkers, We have some data in people living with HIV infection, and this is from the Alcohol Research Center on HIV. Excuse me, my slides keep progressing with a mind of their own. So we have self-report data on people's alcohol use in the past 3 months, their number of heavy drinking days, and we see that correlates very strongly with their SCD14 levels. And we also saw that people who reduced their drinking by at least 50% over 3 months during the course of the study had a significant decrease in SCD14, whereas those who maintained drinking did not show that effect. Okay, so turning now to MRI correlates of neuroinflammation. We have these 3 metabolites here, cerebral metabolites measured using magnetic resonance spectroscopy. Glutamate is the predominant excitatory neurotransmitter in the brain. Choline is a marker of brain cell membrane turnover, and glutathione is a measure of it is the a very prevalent antioxidant in the body and measures antioxidant status and activity. So here again, acute alcohol effects really depend on dose and timing, more of a mixed bag, and then chronic alcohol we see can actually have very similar effects to HIV on these specific MRI correlates of neuroinflammation. And I say correlates rather than biomarkers because they really haven't reached the level of biomarker, but they do mark these processes that are correlated with neuroinflammation. All right, and now acute alcohol effects. So in that same pilot study that I mentioned before, we took MRI at baseline and then at the descending limb of alcohol, so a pre-post design, and we saw significant increases in all of these markers in GLX, choline, and glutathione on the descending limb of alcohol. So what you could interpret that as in healthy people is that excitatory activity and possibly neuroinflammation are increasing, but so is the antioxidant. So a compensatory or kind of homeostatic response in terms of antioxidant activity as well. And we might not see that in people who have a baseline of elevated inflammation, such as people living with HIV. So that's the type of question and hypothesis that my current study is designed to investigate, a study of acute neural and immune effects of alcohol in people living with HIV at the Cadre. Our first aim is to investigate acute effects of alcohol and biomarkers of microbial translocation and immune activation in people living with HIV and healthy controls. And aim 2 is to examine acute effects of alcohol and these MRI correlates of neuroinflammation in people living with HIV and healthy controls. To do so, we have a 2x2 experimental design to look at the effects of these 2 factors, so HIV status, seropositive, seronegative, and alcohol condition, placebo or moderate alcohol on the biomarkers that I showed before. We'll recruit 56 individuals, equal numbers of seropositive and seronegative individuals from the Miriam Hospital Immunology Clinic, where the site PI is Dr. Karen Tashima. And in our alcohol protocol, participants are randomized to condition. We do a double-blinded administration protocol where they receive placebo that looks and tastes like alcohol, but actually contains no alcohol, or moderate alcohol for a target blood level of 0.07, which is right under the legal limit of intoxication, what's also considered the binge threshold. So hopefully enough to detect an effect without exposing people to a risk of the adverse effects that you'd see with a higher dose. I won't go through our very lengthy inclusion and exclusion criteria, but just to summarize, people need to be generally in very good health, to have no lifetime history of heavy drinking, to be current moderate drinkers, to not be taking any medications or have confounding factors, no major psychiatric disorders or safety contraindications for MRI. And then for our HIV specific inclusion criteria, we also require that people be on stable ART for at least 6 months, not on this small handful of drugs that have a remote possibility of acute interactions with alcohol, and to have healthy labs and to not have an active diagnosis of AIDS. So just a quick overview of how the study visits are structured. We do a pre-screening. We have, sorry, these slides keep advancing on their own. A detailed baseline assessment visit 1, and then visit 2, they come back on another day after they've been fasting for a couple of hours. We do the beverage administration after a baseline blood draw, do hourly blood draws thereafter, and then we do MRI on the descending limb. So the dashed line represents breath alcohol trajectory in the active alcohol condition, which is intended to peak at 0.07. And we do, again, we're using this descending limb of alcohol paradigm to look at the MRI markers, specifically cerebral metabolites. And that's under the idea that, during alcohol clearance is when we're going to see sort of compensatory or homeostatic mechanisms of how the brain kind of rights itself after the exposure to alcohol. Here is an image of our magnetic resonance spectroscopy locations. We look in the frontal lobe and the posterior parietal lobe, and both of these locations have been shown in multiple previous studies to be sensitive to both the effects of alcohol and HIV infection. Our project status is that we're ready for recruitment. As of March 2020, of course, as with all human subjects research, we suspended activities due to the coronavirus pandemic, and we're currently developing plans to resume research in the fall. In terms of future directions, I'll just briefly mention, apropos of our wonderful keynote speakers and with the focus on Alzheimer's and aging, we do plan to look in the future at alcohol as a contributor to Alzheimer's disease and related dementias, as there's mounting evidence that alcohol is not in fact protective against cognitive decline or dementia, as was believed for quite some time. And in this, in these studies, we have a similar experimental mechanistic framework where we focus on these same immune-related and inflammatory pathways: microbial translocation, systemic inflammation, and neuroinflammation. And after Dr. Sperling's fantastic talk, I think we might need to include some additional factors in here, such as sex and the interaction with APOE, and also, taking into account the fact that alcohol intake was not associated with amyloid in her studies is also something that we need to look more closely at. So just overall, though, this is our model, and again, progressing the cadre theme of the intersection of substances with chronic disease. So I will thank you all for your time and attention, and thank you for inviting me to be part of the symposium today.
Thank you, Molly. This is great. So here's a question. Can you comment on your career development path from a clinical psychology base toward your current clinical translational research? What research infrastructure was particularly helpful?
That's a fantastic question. So, from the time of pre-doctoral to postdoctoral, I had the advantage of mentors who really encouraged me to apply for NIH funding early with the, F series awards, F31. I was on 2 T32s, both pre-doctoral and postdoctoral at the Center for Addiction. So one was in University of New Mexico, and my postdoctoral work was at the Center for Alcohol and Addiction Studies. And both of those were just tremendously helpful in developing research skills and helping me find sort of my niche in terms of how I wanted to, apply my clinical psychology research and training. And I, from the beginning wanted to study brain behavior relationships. So I've been fortunate to work with mentors and have access to NIH funded research, in those areas.
Fantastic. So we heard from John Sedevy yesterday that people living with HIV are on RT inhibitors, and they suppress inflammation. So could HIV status copy number be a confounder for your studies? In other words, the effectiveness of the drugs in suppressing inflammation?
Yes. So when you say copy number, do you mean like the HIV viral load?
I believe that's what's intended, yes.
Yes. So we do require that people be undetectable. So their medication does have to be fully effective. So they can't have detectable viral load, and that's, using the most sensitive clinical tests that are available.
Great. Do alcohol and/or HIV change the fecal microbiome that's translocating here?
Yes, they both do. And with alcohol, the studies are more still focused in the preclinical and animal models, but that has been clearly shown. And people have also tried, probiotics to remedy those changes with some success, or prebiotics. And with HIV, there's a more robust clinical literature with large-scale human research studies showing that those changes do occur. Yes.
Okay. And does the age of the participant alter the MRI changes caused by alcohol ingestion?
Yes, so in some of these studies where we're kind of narrowing our focus on these pathways, we do have a more limited age range. However, with the work that I mentioned where we're developing, looking at alcohol in the context of aging and potentially Alzheimer's and related dementias, we are, expanding so that we can look at the fuller age range, consistent with NIH's policies on inclusion across the lifespan. And we do expect it to make, things somewhat more complex, but yes, we do expect an interaction of alcohol with aging.
And a follow-up to a previous question, since 16S sequencing in blood is fairly easy and detects translocation, have you thought about using that as a outcome in your studies?
We have, and some studies, so the pilot data that I showed were just, a very small sample, and we did use LPS just as being kind of a more readily available, but we definitely would like to also use the 16S markers to corroborate and potentially round out the information that we're available to obtain.
Fantastic. Okay, wow. Thank you so much, Dr. Monik. It was a great talk. We enjoyed it, stimulated a lot of great discussion, and thank you very much. And we will move on to our next speaker, who is Dr. Shibin Cheng. He is at the Women and Infants Hospital here in Providence, and he is affiliated with the COBRE for reproductive health.
Okay, good morning. Thanks for the introduction. I'm Shibin Chen, represent COBRE for reproductive health. Our COBRE is in phase 1. This slide basically shows an organizational chart of the program. Dr. Sharma is the PI of this program. We have 4 investigators and 2 courses led by Drs. Rouse and Friedman, respectively. The mission of this program is to develop a research infrastructure for a center that supports multidisciplinary, translational, and innovative program in women's reproductive health. The scientific goals are listed here. So I'm one of the investigators of this program, working in the Department of Pediatrics at the Women and Infant Hospital. My research mainly focuses on characterizing the pathogenesis of preeclampsia. Today, I'm going to talk about normal detection assay of proteinopathy in patients with preeclampsia, PE, and Alzheimer's disease. First, I want to briefly introduce some background of our study. Our prior work has shown that preeclampsia, PE, a disease of a younger age, offers a window into understanding the pathogenesis of neurodegenerative disease, such as Alzheimer's disease. And like AD, the PE placenta is affected by proteinopathy, a process of accumulation of protein aggregates. As we just learned from our today's keynote talk by Dr. Sperling, the predicting AD is so important. So we have leveraged our findings to establish predictive assays for detecting protein aggregates and screening for drugs. These publications form the basis of the work I'm presenting today. PE is a placenta-associated syndrome characterized by de novo onset of hypertension and other complications, such as proteinuria after 20 weeks of gestation. PE not only affects mother and fetus during pregnancy, but also increases the risk of many other diseases later in life, such as cardiovascular disease, diabetes, and neurodegenerative disease. Based on a set of clinical syndromes, the PE is classified into early onset before 34 weeks of gestation, and late onset after 34 weeks of gestation. These 2 types of PE have distinct pathological features. Despite the extensive studies, we still don't know exactly the pathogenesis of PE, but we do know PE is a multifactorial syndrome. As shown here, many factors are involved in PE pathophysiology, such as genetics, inflammation, oxidative stress, you name it. All these factors can negatively influence chop blast invasion, spiral artery remodeling, leading to reduced placenta perfusion and consequent manifestations of PE. In addition to these contributing factors, as I just mentioned, protein misfolding and aggregation also act as a causative factor for the pathogenesis of PE. So how are protein aggregates accumulated? As you know, proteins are produced, folded, assembled, and modified in ER. In normal conditions, misfolded proteins can be either refolded or cleared by cell degradation machineries such as autophagy lysosome pathway. However, in pathological conditions, autophagy can be impaired, and as a result, protein aggregates could not be degraded, leading to accumulation of protein aggregates inside cells. Protein aggregates are cytotoxic and can cause oxidative stress, ER stress, inflammation, cell death, leading to protein aggregation diseases. So protein misfolding and aggregation diseases are a group of disorders, including neurodegenerative disorders and type 2 diabetes. These disorders are characterized by deposition of at least one toxic aggregated protein, intracellularly or extracellularly as listed here. For example, as shown in this figure, A-beta aggregates form plaque and deposit in brain tissue of AD patients. As I just mentioned before, our studies have suggested that P as a new member of protein aggregation disease. Our most recent work further suggests that impaired autophagy lysosome machinery are responsible for the accumulation of protein aggregates in the placenta from P patients. So the question is, can we detect the protein aggregates in the placenta and the serum from P patients? Here we adopted a dye called Protistat. Protistat is a Rhode dye as shown here. It has a higher affinity to aggregated proteins, and it can specifically bind to protein aggregates. Once binding to the aggregates, it stops rotation and fluoresces. So using this dye combined with immunofluorescent staining, we found TTR aggregates in P placenta as shown in this figure. This diagram shows the placenta areas we look at. Box A and B indicate microvilli and extravilli domain in the placenta as shown in panel A and B respectively. Here you can see TTR signal in green and Protistat signal in red are strongly expressed in chop blast cell layer of microvilli and EVT in P placenta compared to normal pregnancies controls. Importantly, the TTR and the Protistat signals are well colocalized, suggesting aggregation nature of TTR proteins in P placenta. In addition to TTR, we also identified A-beta and cis-p-tau as protein aggregates in the P placenta, although I don't have time to show the results. Here the question is, can we detect these protein aggregates in serum? Yes, we can, because we have established a novel sensitive cell-based protein aggregation assay for detecting fluid-based protein aggregates. So how does this assay work? As you know, autophagy plays an essential role in clearance of protein aggregates. Therefore, autophagy deficient cells have compromised ability to clear aggregated proteins, which can lead to accumulation of protein aggregates. So we hypothesize that when autophagy deficient chop blast cells are incubated with media containing protein aggregates, so protein aggregates can be internalized and accumulated inside cells. Then accumulated aggregates can be detected with a Protistat dye. First, we generated the autophagy deficient cell line as shown here. And then we exposed autophagy deficient cells to 10% of serum samples and fixed cells at the different time points. The cells will then stain with a protein dye. So protein aggregates can be detected by a fluorescent microscope. To validate this assay, we tested whether in vitro generated TTR aggregates can be internalized and accumulated in cells. To this end, we incubated the cells with media containing TTR aggregates or native TTR as a control. Let's see what happens. So this is the results. At the 15 minutes incubation on ice, you can see a lot of TTR aggregates as detected by protein dye, distributed on the surface of the cells and in the extracellular areas. At the 24-hour, a huge amount of TTR aggregates accumulated inside cells. In contrast, protein signal was not detectable in native TTR-treated cells. This suggests that autophagy deficient cells can internalize TTR aggregates and accumulate TTR aggregates inside cell. So the question is whether this assay also works for serum samples from patients. To test serum samples, we incubated cells with 10% sera from early onset or late onset P or control sera from gestation age matched pregnancy, and then fixed the cells at various time points. The cells were stained with protein dye. Here you can see robust protein signals accumulated in cells treated with early onset P sera in a time-dependent fashion. In contrast, no much signal was detected in cells exposed to control sera. Similar results were also seen in sera from late onset P. However, protein signal is weaker and accumulation undergoes more slowly as compared to early onset P. So far, we have measured over 30 samples. Here is the quantitative data. You can see sera from early and late onset P have significantly higher levels of protein aggregates than their respective controls. And early onset P sera have higher levels of aggregates than later onset P. Now the question is, what are the components of the protein aggregates in sera from P patients? To address this, we combined protein dye staining with immunostaining using specific antibodies. As shown in this slide, we exposed cells to sera from P or control and did co-staining with protein dye and antibodies against the TTR and A-beta. Here you can see higher levels of TTR, A-beta signals and protein signals in cells exposed to early onset P sera, but not control sera. Importantly, TTR or A-beta immunoreactive signal co-localize with protein signal, suggesting TTR and A-beta are components of protein aggregates in P sera. To verify whether these proteins are real aggregates, we ran a native gel to separate protein aggregates from cell lysates. As shown in panel B, huge amounts of TTR and A-beta aggregates with a higher molecular weight were detected only in cells treated with early and late onset P sera. In addition to TTR and A-beta, we also examined alpha-synuclein and serpin-A1. However, both proteins were not detectable in sera treated cells, although a lot of protein aggregates were detected. This results suggest that TTR and A-beta, not alpha-synuclein and serpin-A1, are specific components of the aggregates. Similar results were also observed in sera from late onset P, but I won't show the images this time. Our results indicate that our assay can detect not only total protein aggregates, but also individual specific protein aggregates. Using our assay, we've been able to detect protein aggregates in sera from P patients. Here the question is, does our assay work for serum samples from Alzheimer's disease? So next, using our assay, we tried serum from AD and mild cognitive impairment, MCI. It turned out it works. As shown here, many cells display robust protostat signal when treated with AD or MCI serum, and not control serum. Quantitative data indicates AD and MCI serum have higher levels of aggregates than their corresponding controls. And AD serum have higher levels of aggregates than MCI serum. It's exciting. We were able to detect protein aggregates in serum from MCI because, as you know, MCI is a prodromal AD and a transient condition that may develop probable AD later on. To date, no biochemical test is available for diagnosis of MCI. Our data suggests that serum protein aggregates may be used as a biomarker for MCI, and our assay may be useful for diagnosis of MCI by detecting protein aggregates. If so, using our assay, we can predict the AD onset later on. However, before that, we have to test our assay in larger scale samples. So again, what are components of the aggregates detected in AD and MCI serum? So to address this question, we did co-staining using A-beta, TTR, and alpha-synuclein antibodies combined with protostat dye. In panel A, you can see robust A-beta signal and a protostat signal in the cells treated with serum from AD patients, but not age-matched controls. Similar results were also observed for TTR and alpha-synuclein co-staining. This suggests that A-beta, TTR, and alpha-synuclein are major components of aggregates in AD serum. Similarly, these three proteins were also identified as protein aggregates in MCI serum. However, we found that intensity of alpha-synuclein aggregates in MCI serum is lower than that in AD serum. Therefore, alpha-synuclein aggregates may be used as a biomarker for distinguish AD and MCI and monitor the progression of MCI. To determine whether accumulated aggregated proteins were induced by increased transcription in response to serum, we assessed the transcriptional effect of serum treatment on the mRNA levels of TTR, amyloid precursor protein, APP, and alpha-synuclein using real-time PCR. So total RNA was extracted from autophagy deficient cells treated with various sera at 3, 12, and 24 hours. As shown in this figure, exposure to AD or PE sera did not significantly alter mRNA levels of these proteins over the time course. This suggests that accumulated aggregates are not induced by transcriptional induction, but rather did directly come from sera. In conclusion, so our protein aggregates assay is novel, sensitive, and cost time effective. Using it, we were able to detect the protein aggregates in sera from early and late onset PE, Alzheimer's disease, and MCI. TTR and A-beta were identified as major components of protein aggregates in sera in AD sera and MCI, and alpha-synuclein only in sera from AD and MCI with lower intensity of alpha-synuclein in MCI. So the intensity index of alpha-synuclein proved to be a major difference between MCI, AD, and PE sera. Our assay may be useful for detect the presence of protein aggregates in determining their quantity and identify components of aggregates. This might be helpful for preclinical diagnosis of proteinopathy diseases, monitor disease progression and potential drugs for treatments, and evaluate efficacy of treatments. So I would like to thank my mentor, Dr. Sharma, for his wonderful coaching. Many thanks to my colleagues, especially to Sayani Banerjee. She did almost all the experiments and the quantification, and she did a great job. many thanks, also many thanks to our collaborators, our cause, and funding support as well. Thanks so much. Any questions?
Very good. Thank you so much. Bravo. That was a really very interesting discussion. I have a question, whether this proteostat method could be used to identify autophagy deficient cells in tissues, such as conditions under where it's thought that impairment of autophagy might be part of the pathophysiology of the disease process.
So actually, we use this protease dye can detect the protein aggregates in autophagy deficient cells treated with some ER stress inducer like hypoxia and other ER stress inducers. Yeah, and also we can detect the protein aggregates in autophagy knockout placenta. Yeah, in mouse.
Are the aggregates expected to be modifiable in response to therapy, such as anti-inflammatory therapy?
So this is what exactly we are going to do. So we actually trying to detect the protein aggregates in serum from early onset, early gestation date. Actually, we have some pilot experiment, and we got some preliminary data. We can detect the protein aggregates even in early gestation date.
Okay, and another couple of questions. Can the how do you interpret some alpha beta aggregates in native gels and the controls when there was no signal in the colocalization microscopy staining? That refers to one of your slides, I believe.
So the alpha-synuclein in native gel?
I presume so, yes. Alpha beta aggregates, no.
Okay. A-beta, we really detected A-beta traceritin, but because alpha-synuclein is not present in the serum from PE, so we didn't do the native gel.
So, quick question: are the cells used in these experiments from a preeclampsia patient, or are they a laboratory construct?
This cells is autophagy deficient cells were generated from a first trimester trophoblast cell line from the normal pregnancy.
I see. Great. Fantastic. Well, thank you very much. Great talk. Our next speaker is Masha Frank. Sorry about that. My error. Who is in the Department of Psychiatry and Human Behavior at the VA. And she's representing the Cobre Center for Neuromodulation. Take it away.
Yeah, thank you so much. And hello, everybody. And I'm excited to share some of my work that I've been working on. Before I do that, I will first introduce our Cobre Center for Neuromodulation, and which has as goal to advance clinical research in non-invasive brain stimulation. Our overarching idea here is that in order to fully realize the promise of non-invasive brain stimulation, which is currently a clinical treatment for some illnesses, we must better characterize its behavioral effects as well as the mechanism of action in the brain in relevant clinical populations. This is a phase 1 Cobre that started in March of 2019, and the director is Dr. Greenberg with Dr. Linda Carpenter as the deputy director. Our Cobre administrator is Kristen Fortin-Ashburn, and besides the parent institution Butler Hospital, we work very closely together with the Barney Institute for Brain Sciences at Brown University, as well as the Providence VA Medical Center. Currently, this group supports 3 projects and project leaders, and pilot projects are to begin this year. It also includes 2 research cores, the Design and Analysis core, which, as you may guess, supports experimental design and data analysis, and the Neuromodulation and Neuroimaging core, which supports the methods development and data acquisition for brain stimulation, MRI, and soon electrophysiology. So with that, I'll move over to the data science part of this talk and briefly introduce myself. I have a background in cognitive neuropsychiatry, and besides being a project leader on this COBRI, I am an assistant professor in the Department of Psychiatry and Human Behavior at Brown University. I'm also affiliated with the Center for Neurorestoration and Neurotechnology at the Providence VA. And today I will talk about data from a study on the effects of transcranial direct current stimulation on the ability to stop avoiding what no longer poses a threat. Now, clearly, we wouldn't have this symposium this way if our daily lives were not dominated by avoidance at this time. And I am literally overrun by advertisements for face masks, all aiming to limit the spread of COVID-19. And right now, this avoidance is actually a good thing. We want to keep doing it. In fact, avoidance is very useful when done to achieve relatively short-term goals, such as flattening the curve of hospitalizations. But in the long run, avoidance tends to create havoc. And the long-term negative impact of avoidance is apparent in PTSD. So in PTSD, the often intense fear associated with traumatic experiences generalizes to everything in daily life. And it is thus only logical that people want to avoid situations and reminders of the trauma. Yet the continuous avoidance results in persistent anxiety, as it prevents the occurrence of corrective learning, namely that these memories and reminders of the trauma itself are in fact not dangerous. And exposure-based psychotherapy, which is a first-line treatment for PTSD, aims for such corrective learning. And during exposure, patients are repeatedly confronted to reminders of the trauma. And this can occur, for instance, through imagination or imaginary exposure, or virtual reality more recently, which is something that we do actually at the Providence VA, where we combine virtual reality exposure with non-invasive brain stimulation. But this exposure allows for the generation of new safety memories that then inhibit the excessive fear. So in other words, the success of exposure-based psychotherapy relies on adequate corrective learning and memory. And our surrounding or context is critical for corrective learning and memory. Namely that no IED will blow up when driving on a specific stretch of the I-95 from home to the VA. Now, unfortunately, these contexts are very specific, narrow, and do not generalize well at all. That means that those who have PTSD will continually need to train themselves to learn and remember a potentially infinite number of safe contexts. So we thought, can we perhaps change how the brain would normally contextualize learning? And we know that prefrontal cortex and hippocampal connections are critical for the processing of context. So by suppressing this circuitry, using transcranial direct current stimulation, perhaps we may suppress the encoding of contextual information as well, meaning that learned information can then more easily generalize to novel contexts. So to test this, we ran 2 separate studies, one at the Providence VA and one at Brown University. And I'm going to show you here briefly some demographics of these participants, wanting to draw specific attention to the fact that these were healthy people in either study, and that half of the sample in both of these studies received the active transcranial direct current stimulation, or TDCS for short, and the other half received fake or sham stimulation. So it looks and feels a bit like TDCS, but is not actually an active current that is running through the brain and modulates neurons. So in both of these studies, participants played a game. Well, actually, this is about the least fun game you could play. Because in this game, you can only lose or nothing happens at all. You can never win. And I'm going to warn you here already in advance, there's some sound here that may sound loud. I cannot change that. So the idea here is that people are being asked to make a decision between two images on the screen. And over time, and with many repetition, you will learn that when you select one image, there's the sound, you will lose. And if you select the other image, nothing happens at all. So once you have learned these rules, we're going to switch them so that now the image that didn't result in a loss results in a loss, and the image that did result in a loss no longer does. So there's some important information here that could give away that something has changed. And that is the background color behind these images or the context. Now, even though this context change may have seemed very obvious to you, in truth, this game is a little bit more complex. And what you'll see is that it's a little bit more subtle when you actually do this task. But in this game, context is everything, because context allows you to know which image to avoid and which image was safe. But context also restricts, because you can only know which image was safe when you have seen the particular context before. So what if you now give you a totally novel, never seen before context? Which image would you choose? Given that you have only seen two contexts, namely the orange one in which the yellow image was safe and the green context in which the purple image was safe, you may not really have much of a preference. But this is precisely what we do not want to see happen after exposure-based therapy. Because exposure always happens after trauma, we only want people to generalize the last learned rules, namely that the purple image is now in fact safe. So I'm going to show you some data what we found in our VA sample. And when we applied fake or sham stimulation during the corrective learning phase, namely learning in the green context, and then test this in the novel context, you see that participants do not actually have much of a preference. But when we applied active stimulation, active TDCS during this corrective learning phase, you see that now participants indeed generalize the last learned rule to this novel context as we hoped. Now, unfortunately, we were not able to replicate this in the Brown data set. And what we found here is that even though we applied fake sham stimulation during the learning, you see that participants already are generalizing the last learned rule to this novel context. And TDCS did not actually have a significant effect. And one of the reasons for that, why this may be, is because of the difference in demographic between these groups. So as I showed you very briefly before, in the Brown data sample, it was mostly graduate and undergraduate students who are more familiar with the stacks, are typically younger. Whereas in the VA data sample, you see that the participants were older and perhaps less used to these types of experimental tasks. And to highlight that a little bit more, you can see that in the learning rate during corrective learning. So if you compare those where here the white line represents the active TDCS condition and the orange represents the sham condition, you see that not only in the VA data set is the overall learning rate decreased and the overall performance lower, the suppressive effect of TDCS in the white line is, oh, do I have a mouse? I have this, I don't know if you can see this. In the white line here, you can see that it's much stronger as compared to in the Brown data set. So there are some interesting results here that will require follow-up research. We'll be happy to do and continue doing so after we are being able to do in-person visits again, which hopefully is soon. And together with other previous research that we're doing, as well as the COBRI study, we're getting closer to understanding how transcranial direct current stimulation may help ultimately enhance exposure-based treatments for PTSD. But for the more immediate future, I hope that soon we can quite literally see each other again and stop avoiding each other. And it may unfortunately be a couple more months. So in the meantime, have a very pleasant summer. And with that, I would like to thank you and also my collaborators and the larger COBRA team, especially Dr. Sarah Garnat, who has been a collaborator on this project, as well as Dr. Noah Phillip and Rebecca Burwell, who are my mentors, and my wonderful RAs, Julia, Alexis, Christiane, and Atticus. Thank you.
Fantastic. Thank you very much. One question, the Brown sample was primarily female and the VA sample male. Is the difference between men and women in the effective stimulation and a factor? In other words, the sex a factor? And is there precedent for that kind of difference?
Yeah, that's a great question. So, the studies that we typically run at the VA tend to be predominantly including a lot more males than females, whereas for Brown studies that is exact opposite. So it allows us to take a look at what the differences are, which is to compare between cross samples that may be difficult due to other demographic changes. But when we look at within data sets, we have so far not seen any evidence that the effect of transcranial direct current stimulation is different for men and women.
Is there a role for transcranial stimulation, magnetic stimulation in treatment of PTSD?
Yeah, so this is one of the studies that we're running at the VA right now, which is funded by Merit. So here what we do is we bring people through a virtual reality exposure. So they're wearing the headset, and what we're doing is we're putting the electrodes on the scalp. So TDCS, or transcranial direct current stimulation, as opposed to other neuromodulatory techniques like transcranial magnetic stimulation, really allows the movement of the head. It's very flexible. You can move around. You can do things. So that combined treatment, while people are learning to habituate to the traumatic memories and reminders, you see that the transcranial direct current stimulation may actually speed up that habituation. Right now this is based on pilot data. Right now we're in the Merit, we're fully blinded, so we don't have the results, but from tracings of the psychophysiology, the amount of sweat in the hands, we can already see that some people react really well to it, whereas others may not. But if they're pretty active in shampoos, we don't know.
Okay, great. Do you, you're anticipating restarting the clinical trial in the fall?
Yes, we're actually working on some implementations right now to restart and making the best decisions to go forward. So yeah, that is definitely, we're hoping to open as soon as possible.
And when you do open, will you be collecting any biologics, hormone levels, epigenetic markers?
So we are not collecting hormone levels, and I would be interesting to hear more about that if somebody has an idea about that. But we are doing brain scans, so we're looking at biomarkers related to cognitive structuring and functional connectivity.
Fantastic. Okay. I'm not seeing other questions, so I thank you very much. Terrific presentation, very interesting, and we will look forward again to meeting again before too long. So our next talk is Dr. Beth Bergwijn-Fuchs from the Miriam Hospital and Rhode Island Hospital, and she's representing the COBRI for antimicrobial resistance and therapeutic discovery. Take it away, Beth.
Thank you so much for that very kind introduction. Yes, as you just said, my talk today is representing the Center for Antimicrobial Resistance and Therapeutic Discovery, funded by the COBRI grant. Pharmaceutical companies have largely abandoned the idea of developing new antibiotics. So that mantle has been taken up by academia and also startup companies and small biotechs. So it's up to us to come up with the next, with the next round of, now, oh, there we go. The principal objective of the card is to build a unique multidisciplinary center to study mechanisms of antimicrobial resistance and develop therapeutic countermeasures. The team is led by the project director, who is Eleftherios Malinakis, Chief of Infectious Diseases at Rhode Island Hospital. Currently, there are 3 projects within the CART looking at various aspects of antibiotic resistance and challenges, and 1 pilot project. The CART currently hosts 2 cores. You're welcome to take a picture of this screen. That's why I have the camera up there, so you can capture the contact information. But our cores are the biorepository core, led by Dr. April Bobenchek, and an animals monocore, led by Dr. Jerry Now. You're also welcome to take a picture of this slide if you like, or capture a screenshot. Dr. Bobenchek is curating a collection of microbial samples. You can contact her directly about accessing portions of the inventory and learning more about the assets. The website for the biorepository core is under construction, but samples can be obtained by contacting her directly. Again, her email is listed at the bottom of the slide, so that you can contact her about accessing the samples for research purposes if you would like. And she can provide you with more detailed information about the specific samples that are in the collection so far. So I would like to start off by taking the opportunity to tell you about my project that falls within the card and delves into the issue of new antimicrobial drug discovery. With an increasing need to expand the pharmacopoeia of drugs that can combat antimicrobial resistance bacteria, we sought to identify new antimicrobial agents. Our search led us to focus on the target thioreductin reductase. A drug that explores this new target as a proof of concept is Aronafin, which is already an FDA-approved drug that was approved back in 1984 for treating rheumatoid arthritis. So drug resistance is an expanding problem. There are millions of infections annually and can range in seriousness from skin infections upon barrier breaks, disruption to normal microbiome, which can have normal causes for that source, or life-threatening systemic infections. Part of the infection status is dependent upon the underlying health of the infected individual. Suppressed or compromised immune systems can lead to individuals in a vulnerable state. Aging can represent a vulnerable state as the immune system can become less responsive to invading pathogens and allow microbes to go unchecked and establish an infection. This is exacerbated by the growing emergence of drug-resistant microbial strains. 2 million people get antibiotic-resistant infections annually, resulting in 23,000 deaths. Part of the drug resistance issue is driven by inappropriate drug prescriptions, but this is being addressed by greater efforts on drug stewardship. However, even with these measures in place, drug resistance continues to mount. With expanding drug resistance, there's a need for new antimicrobial agents, especially ones that address new and novel microbial targets. My lab is specifically focused on Staphylococcus aureus. It's one of the leading causes of bacterial infections. Perhaps the fecundity of the infection is associated with the fact that it's part of the human skin microbiome, so it's always already there for most people. As a prominent resident in the skin, and barrier breaks can present easy access of bacteria that under the right circumstances can lead to an infection. These infections can be as simple as just an abscess that gets, just a skin break that gets infected and causes an abscess. But under the right circumstances, it can lead to more threatening situations such as sepsis. It is interesting to note that you can either have hospital-acquired or community-acquired infections. And it's my understanding that Medicare is leading to a scenario in which hospital-acquired infections, such as hospital-acquired staph infections, maybe would not be reimbursed. So there is the incentive to either prevent or quickly treat these hospital-acquired infections. We have a number of effective antibiotics that are disposable to treat Staph aureus, but that arsenal is being affected by drug resistance. This is not an exhausted list by any means for available antibiotics, but it does demonstrate the developed resistance, such as methicillin resistance, vancomycin resistance, vancomycin intermediates, linezolid resistance, multi-drug resistance. Therefore, drug stewardship and antibiotic resistance potentials are both aspects that need to be considered when developing new compounds. So we have an overall strategy when we identify new compounds and a process to validate the antimicrobial efficacy. The process starts with compound discovery via screening. The work started with a high throughput, let me see if I can use my cursor, yeah. The high throughput screen to utilize the nematode C. elegans as an infection host. The worm has proven very useful in an infection model and is susceptible to a number of bacterial and fungi. Worms are normally maintained in the lab by consuming E. coli as a food source. However, this food source can be switched out for other bacteria or fungi to see an infection model. The worms ingest the bacteria, in this case Staph aureus, and it travels to the gut and establishes an infection. We have screened approximately 89,000 compounds in one of our screens and had 167 hits. 2 of the hits from the screen were aronafin and chiconin. Aronafin, like I mentioned previously, is FDA approved in about 1984 to treat rheumatoid arthritis, and it's a gold-containing compound. Chiconin is a Chinese herbal medicine derived from lithsperm root. And if you can imagine in the rhizosphere, there can be bacteria around the root systems. It's not surprising that plants have already kind of devised a system to prevent bacterial infection or bacteria from penetrating through their systems. Let's see. In recent screening process, worms died of a lethal staph infection when they were only provided with DMSO, indicating by the cytox staining here that you can see. However, when the worms were provided with an antibiotic like vancomycin, we don't see staining, which indicates that the worms were able to survive and their lifespan was prolonged. We also see that there's no staining with chiconin or aronafin, again indicating that these compounds were able to rescue the worms from the infection process. When we look at C. elegans in a dose-dependent manner when they're provided with aronafin, we see that aronafin is able to prolong the worm's survival starting at about 0.78 micrograms per mil. And this is slightly better than the gold standard medication of vancomycin. So for most of this talk heading on, I'm going to focus on aronafin and only have occasional mentions of chiconin. But aronafin was able to show a minimal inhibitory concentration against Staph aureus at about 0.25 micrograms per mil, and chiconin was at 4 micrograms per mil, indicating that both of the compounds were looking pretty good and caused bactericidal effects. So in the literature, we had the advantage of being able to have an understanding of what the potential target of aronafin was, because other people had been studying this in parasites and seen that aronafin could bind to thyroreductin reductase, and they were seeing this in X-ray crystallography. So we kind of took that as a hint of what our target could be in bacteria and began to look at the thyroreductin reductase system as a probable target. And the thyroreductin reductase system is made up of NADPH, thyroreductin reductase, and thyroreductin. The interesting thing about this system is that gram-positive bacteria are solely reliant on this thioreductant reductase system. But in gram-negative bacteria, they can have sort of a backup system called a glutathione system that can serve the same purpose. So it becomes essential in gram-positive bacteria, where it acts as an antioxidant system and prevents the buildup of reaction oxygen species that can lead to apoptosis. When we provide cells with their minimal inhibitory concentration of either uranofin or chauconin, we do see an accumulation of reaction of oxygen species, which again suggests that we were kind of headed in the right direction and that this thioreductant reductase is the potential target here in bacteria. We also see that when in a, we used an enzymatic assay that takes DNTP, DTNB, and is reduced by thioreductant reductase to TNB using a colorimetric assay, which produces a yellow color. We see a dose-dependent response in reducing thioreductant activity. We then think, okay, so if gram-negative bacteria have this glutathione backup system, could we then add glutathione into the reaction and increase the minimal inhibitory concentration? And yes, that does occur. So the data shows us that inhibition of thioreductant reductase can lead to staph inhibition. We therefore move to detect the potential to develop existing drug resistance. Our interrogation of existing uranofin resistance mechanism initiated with the test of clinical isolates. The isolates were provided by April Bobenchek, whom I mentioned previously as part of our biorepository core. These specific samples haven't been deposited into the core yet, but we hope to make those available to her. We tested 500 clinical isolates from Rhode Island Hospital, and the highest frequency, sorry, my mouse is a little bit delayed, was for between 0.25 and 0.5 micrograms per mil. We then used a collection that was smaller, made available by Dr. Erica Diagata. And the important part about this collection was that, one, it was outside of Rhode Island, and also her collection was predominated by drug-resistant isolates. And here we see the MIC was predominantly about 0.25 micrograms per mil. We then also tested a CDC collection of visa isolates. So these are drug-resistant isolates again, and saw that our MICs were about 0.25 to mainly 0.5 micrograms per mil. So in total, with all of the over 500 clinical isolates that we were testing, we saw a range between 0.25 to 0.5 micrograms per mil, and only saw 4 isolates with the highest MICs of 1 microgram per mil, which suggests that there isn't a naturally existing already resistance mechanism to uranofin, which is good. We then tested to see if there could be, as you can see in panel E, a low dose exposure developed resistance over time. And when we compare ciprofloxacin to uranofin in an MW2, which is a drug-resistant strain of Staph aureus, thankfully, uranofin did not develop resistance over time. So it suggests that there aren't resistance mechanisms either already in place and they don't develop quickly over time, which is not to say that they couldn't develop over extended use or in clinical practice. So this is something that still needs further investigation. Now, somewhat unfortunately, our competitors from the Harvard lab, they beat us to the punch and tested uranofin in a peritonitis murine infection model. Thankfully, they did find that uranofin was able to prolong the survival of the infected mice, which again indicates that we are on the right track for the target. So we then moved on and decided to look at the potential for uranofin to impact biofilms. In this case, we used catheters as our model. Catheter bloodstream infections contribute to 200,000 cases of infections annually. The bacteria can enter through the catheter, which kind of contributes to sort of a barrier break. And the infections can cause mortality, extend length in hospital stays, and increase the overall medical cost for treating a patient. And once again, I'll remind you that Medicare has stated that they were probably not going to be continuing with these hospital-acquired infections. So it's an attribute to be able to treat these effectively. Oops. Here we go. So in collaboration with the Schuchler lab, we kind of posed the idea of having these drug-coated catheters. So the idea of coating catheters with materials isn't necessarily novel or new because it's been done before with silver oxide. But working with the Schuchler lab, our co-mentor graduate student Luke was able to generate coated catheters using a dip-coated method. The created catheters were dipped in a solution of THF with polyurethane and auranofin. Polyurethane serves as a carrier to bind the surface of the catheter material. The bonded attached with polyurethane created an attachment for the auranofin so that it released over time rather than a quick payload release. Our initial experiment was to determine the release profile for coated materials. Using our coded protocol, the highest drug concentration could be released up to 26 days. This is significant because normally you think that, you could have infections within 72 hours or so. So to be able to extend the life of the catheter would be important. There was a large amount of the drug released immediately, but a burst release within the first 24 hours. And then the drug release rate became more stable. Importantly, even the lowest tested concentration exceeded the MIC for planktonic cells. The IC50 determined by Torres and colleagues for inhibiting mature biofilms is approximately 16 micromolar, which is about 10 micrograms per mil. And we reached this necessary concentration with a loading concentration of 10 mg per mil of auranofin. We next looked at bacterial inhibition and the drug release from catheters, this time using a 20x higher concentration of bacteria than seeded into our previous MIC assay. This was achieved by daily transfer of drug-coated catheters from fresh solution daily. We find that compounds lasted approximately as long as they did in the measured MIC assay in the previous image that I showed. Thus, we can get multi-day drug release profile using a dip method, using polyurethane as the carrier. We then examined the inhibitory capacity of the catheters material using a Kirby-Bauer assay by bisecting the catheters, the coated catheters, and exposing each surface to the side of the lawn of the bacteria. At all tested concentrations, we see bacterial inhibition by the halo that's formed around the catheter, and the outer surface indicating that the drug is likely being released from the catheter. When the overall mechanism, we next examined the ability of the catheter to inhibit biofilm formation in vitro. So catheters were exposed to cultured cells and allowed to develop biofilms from the adherent cells. We used the MRSA bioluminescent strain USA 300 to visualize the biofilm development associated with the catheters. We find the catheters coated with the polyurethane alone experience a reduced biofilm compared to the coating or drug alone. Biofilm catheters can be seen associated with the vancomycin-coated catheters. Although effective against planktonic cells, vancomycin is poor protector against biofilms. So polyurethane plus auranofin were resistant to biofilm development. This was confirmed when we tested the dry weight of the catheters after removal from the liquid assay. The bacteria showed that there was no recovery of bacteria from the polyurethane and auranofin-coated catheters, suggesting that we were able to prevent the biofilm formation in this case. So in conclusion, the data demonstrates that the thioreductive reductase can be a target. And this was one of the most important things that we wanted to be able to achieve, was to show that we could find a new target, a novel target for drug development that would impact bacteria, specifically gram-positive bacteria. SRAS inhibition by Aronafin suggests that repurposing a path forward for resistance may not be problematic as some other available antibiotics. So we didn't see resistance to Aronafin either from existing mechanisms or low-dose short-term exposure. And we kind of explored an application of this as well with the coating catheters with Aronafin, and we don't see the accumulation of biofilm formation. So going forward, we have a suggested target that we're working to develop further. We're doing additional screenings using thyroreductin reductase as our target to find even new compounds, so not Aronafin, but new novel compounds, and developing analogs for these to see if we can kind of generate a new class of antibiotics. Of course, there's always many people to thank in these. I have a lot of collaborators and wonderful people that I work with in the lab. I'm very appreciative for all of the efforts that they put forth. I'm also kind of appreciative. I've been very lucky to get some of the grants lately. So I was able to get a Dean's Award from Brown that gave us the initial data to apply for a pilot grant from the University of Rhode Island, their COBRA. And that matured so that we had the data to support a project within the CARD COBRA. And most recently, I had a short-term grant from the INBRE for a new project developing new antimicrobials for a different project. But I'm very appreciative of all the help that I've gotten. Thank you. I'd be happy to take questions.
Fantastic. Thank you very, very much. Couple of quick questions. What about toxicity of Aronafin?
So Aronafin doesn't have very bad toxicity. Again, it's an FDA-approved compound, so I kind of think it helps our argument here. The same is not true for Shoconin, because we do see some toxicity levels with Shoconin more towards liver cells. So I don't think we'll be pursuing that one, but what these compounds give us are good information about the interactions between the drug and the target. So they've been able to give us information about how Aronafin binds to thyroreductin reductase, so we can even move forward with new analogs and new drug development based on these bindings, and we do keep toxicity in mind.
And another question, do mammalian cells or fungal cells have thyroreductin
reductase? The answer is yes. So in the case of mammalian cells, they have both the thyroreductin reductase system and the glutathione reductase system, but they have it a lot more, so they are less susceptible to thyroreductin reductase inhibitors. I will say the exception are fast-growing cancers, which have an elevated expression of thyroreductin reductase. And I think there's 6 or 8 clinical trials going on right now using Aronafin as an anti-cancer drug as well. So that's kind of highlighted kind of the importance of this target moving forward in just basic drug understanding and drug development. So we were excited about that. Oh, and about fungi cells, I forgot about that. Yes, so again, some are glutathione dependent and some are glutathione independent. So we did test this in fungal cells, and we see that Cryptococcus neoformans as a fungi is very susceptible to Aronafin. Candida and some non-albicans Candida albicans and some non-albicans species do have susceptibility as well, but I think we have much to learn about which fungal pathogens are susceptible, and it helps to know which ones are glutathione dependent versus independent, and how many copies of the thyroreductin reductase allele they have.
Fantastic. Well, thank you very much. Great talk. And bravo, Vaughn. To our next talk, which is Jill Kryling, who is in the faculty of the Molecular Cell Biology and Biochemistry Department at Brown, and she's representing the Stem Cells and Aging COBRA.
All right, thank you, everyone. My name is Jill Kryling, and I am an associate professor at Brown University, and I am part of the Stem Cells and Aging COBRA. So before I get started, I wanted to give a brief overview of the Stem Cells and Aging COBRA. We are currently in year 3, about to enter year 4 on July 1. And
No, your screen isn't being shared.
really? Oh, this was my introductory slide. Okay, so now I was talking about the stem cells and aging COBRI. So I said we're in year 3, about to go into year 4. This is a phase 2. This COBRI is headed by Dr. Peter Quisenberry at Rhode Island Hospital, as well as Dr. John Sedevy at Brown University. And the projects that are part of this COBRI really focus on the role that aging stem cells and their microenvironment affect the development of aging phenotypes and pathologies. There are 2 projects at Rhode Island Hospital that are using hematopoietic stem cells, and 2 at Brown University that are using neural stem cells. And I have one of the projects that looks at neurostem cells. In addition, we have some core facilities associated with this COBRI. We have the flow cytometry core run by Mark Dooner, the lentiviral core that's run by Olin Lang, and the vesicle core, which is run by Sisheng Wen. Now, as I mentioned, I have a project on this COBRI that focuses on neural stem cells, but that's not what I'm going to be talking about today. Instead, I'm going to be talking about some results that we've gotten from a Alzheimer's disease supplement that we received for this COBRI project, and it's specifically to look at the possibility of using salivary extracellular vesicles as biomarkers for Alzheimer's disease. So we had a nice introduction this morning into Alzheimer's disease by Dr. Sperling's talk. But just to go in brief introduction here, Alzheimer's disease is a progressive neurodegenerative condition that affects approximately 5.7 million people in the US, and it's currently the 6th leading cause of death. And despite decades of research, there are currently no treatments available to either reverse the disease or prevent the onset and progression of the disease. And there are no easily accessible biomarkers to be able to identify people who are at risk of developing this disease. As we heard this morning, they have some promising evidence doing PET scans. However, PET scans are expensive and they might not be covered by insurance, especially if you have no symptoms, and they might not be available to everybody, especially in people that live in more rural areas. Another possible biomarker lies in assaying the cerebral spinal fluid. However, that too is invasive. A lot of people would not want to actually go through that, and they would, especially if they did not have any signs of the disease. So there is a need to develop biomarkers to identify people early on when treatments may be more effective. So we chose to look at salivary vesicles. These are extracellular vesicles that are found in the saliva. And we chose to look at these vesicles because Peter Quisenberry's group had published last year that they could find distinct changes in the contents of these salivary vesicles in patients that had head trauma. And so we wanted to see if the same was true with Alzheimer's disease. So what are extracellular vesicles? They are essentially vesicles that are extruded from the cell, and there are several different types. The ones that we are interested in are the exosomes and the microvesicles. Their cargo consists mainly of RNA and protein. Now, for years, it was thought that these vesicles contained essentially the garbage of the cells, that it was thought that the production of these vesicles was essentially just the cells taking out the trash. However, recently, that's been discovered that that's not the case. It's actually a very important mechanism of intercellular communication, and it's been found that the contents of these extracellular vesicles can affect cells that are quite far away from their cells of origin, especially if they get into the bloodstream. So First of all, pretty much all cells create these extracellular vesicles, including the cells in the brain. And you can see here that pretty much all of these cells are producing vesicles that are affecting both similar cell types as well as other cell types in the vicinity. In addition, these vesicles can cross the blood-brain barrier and enter the bloodstream. Now, it is thought that in the disease state that the contents of these vesicles can change. When they change, they can negatively affect the surrounding cells. So this was the basis of looking at the salivary vesicles, because the salivary glands themselves are innervated by cranial nerves 7 and 9. And these cranial nerves have their cell bodies are actually present in the brain. And therefore, things that are going on in the brain with the disease process could affect the secretion of vesicles by these branches. And these vesicles that can be excreted into the salivary gland can either end up themselves in the saliva, or they can affect the salivary gland cells themselves and alter their vesicle content. So in order to do these studies, we developed a collaboration with the Alzheimer's Disease and Memory Disorders Clinic at Rhode Island Hospital. And we got them to collect saliva from their patients. So essentially, we have patients doing exactly what you see here. We have them spit into the tubes. We aim for about 5 mils of saliva per person. And then we are able to isolate the extracellular vesicles by differential centrifugation, followed by RNA isolation. And we then will look at these on the Alzheimer's disease array or the inflammation array. And both of these PCR arrays have about 96 different transcripts. So far with our salivary samples, we have looked at about 30 normal patients on the Alzheimer's card and 22 normals on the inflammation card, and slightly less of our diseased patients. We looked at patients that had a clinical dementia rating of 0.05. This is a score that is given to the people after they've been tested for a number of different parameters. And 0.05 is basically akin to the mild cognitive impairment that Dr. Sperling was talking about this morning. In addition, we looked at patients that had a clinical dementia rating of 1.0. And these would be patients that would be in the early stages of Alzheimer's disease. So when we looked at the correlation in expression, we did see that there were genes that are differentially, or I should say transcripts that are differentially found in these vesicles, because they're not actually expressed in the vesicles, they're packaged into these vesicles. And we found that although they were quite similar, we do see a reduction in the correlation coefficient. When we started to look at the individual genes themselves, here I can explain this volcano plot briefly here. So no change at all is here at 0, and downregulated is this direction and upregulated to the right. So everything to the left of this line right here is twofold downregulated, and those are indicated in green. And everything to the right of this line here is upregulated, and those are indicated in red. And what we found on the Alzheimer's disease array is that there were 9 transcripts that were consistently upregulated in patients with clinical dementia ratings of 0.5 and 1.0. And we also found 3 transcripts that were consistently downregulated in those same groups. So when we took a look at these, now all of these are related to Alzheimer's because they are on the Alzheimer's disease PCR array, but we do see things that we would expect to be changing in Alzheimer's disease, such as the amyloid precursor protein binding protein or presenilin enhancer. These are genes that we would expect to be upregulated. Now, when I did hierarchical clustering of the individual samples, I did find distinct patterns here. So on the left here, this just shows the entire clustering. However, I thought it would be difficult for you to read the actual samples. So this here on the right is actually just the blow up of this area here. And you can see here, so each one of these is an individual. It shows their unique identifier, and it also shows what their clinical dementia rating was, with 0 being normal, and then the 0.5, 1.0, and 2.0, and whether they were male or female is the M and the F. And you can see here that on the left, we get most of our normals and mildly cognitive impairment individuals are clustering more here on the left, where we're getting our more advanced dementia patients clustering more here on the right. So this was exciting in that we are able to see distinct changes that are occurring in these salivary salivary vesicles that are consistent between the different dementia groups. We also took a look at the inflammation array, and again, we saw that there were some genes that were differentially shown in abundance in these vesicles, and again, the correlations were high, although they were below 1, so there were some differences there. However, when we looked at the individual genes, we only found 2 that were consistently upregulated between the 2 different dementia rating groups, and none that were consistently downregulated. So this did not yield as many markers as our Alzheimer's disease array. And these 2 happen to be receptors that were both upregulated. So as I mentioned earlier, that these vesicles that are produced in the brain have been shown to be able to cross the blood-brain barrier. And we wanted to see if we would get similar results if we looked at the extracellular vesicles that are found in the blood. And we happen to have blood from all of these individuals, because all of them were patients that were being seen at the Alzheimer's and Memory Disorders Clinic. So we isolated the extracellular vesicles from the blood and did the RNA isolation and ran them on the same 2 cards. This is a work in progress, so we haven't done quite as many samples as we have with the salivary glands so far, but so far we have about 20 normals and about 12 of each of our dementia ratings. Again, we did see that there were some genes that showed differential expression between the 2 groups, between normals and the both dementia ratings. However, we did not see consistent changes in particular transcripts between both of these dementia ratings. In fact, there was only 1 gene that was consistent between the 2 dementia ratings that was significantly downregulated, and none that were significantly upregulated. And again, we looked at the inflammation array, and again, we saw a very similar pattern. However, once again, we did not see the same level of consistency that we saw with the salivary vesicles on the Alzheimer's array. And in this particular inflammation array, we only saw downregulation of 2 genes that were consistent between the 2 groups, and none that were upregulated. So based on this data, we can say that the salivary vesicles seem to be a better match for using as biomarkers for Alzheimer's disease patients. We did see a consistent increase in the presence of 9 transcripts in these vesicles, and a consistent decrease in 3 transcripts on the human Alzheimer's disease array. However, we did not see this same level of changes on the human inflammation array, which was actually surprising, because it's known that Alzheimer's disease does create an inflammatory response within the brain. So we did expect to see a little bit more of these inflammation markers coming up, but we did not And the vesicles isolated from the blood showed very minimal consistency. Then this could be because there are many vesicles in the blood. They originate from all different tissues. So the ones that are produced in the brain are likely diluted out in the blood. So with that, I would like to thank the members of my lab and my collaborators at Rhode Island Hospital, specifically Peter Quisenberry's group, as well as my collaborators with the Alzheimer's Disease and Memory Disorders Center at Rhode Island Hospital. This is led by Brian Ott, and Lori Diallo has been instrumental in getting the samples to us, as well as my sources of funding. And I'd like to thank you for your attention. I'd be happy to take any questions.
Fantastic. Thank you very, very much, Jill. So a question here. Can you tell us how you know the exosomes in the saliva are originating from the brain?
Well, with these ones, we haven't looked specifically at the markers, but when Peter Quisenberry published his paper last year, they had shown that there were certain markers indicating that these were indeed exosomes from the brain.
Okay. I noticed that IL-1 beta was downregulated on your Alzheimer's array for the salivary vesicles, but it didn't appear on the inflammation array, which is a little surprising.
Yeah, I'm not sure if they it should be on the array you would expect, but it did not show twofold change when we use the inflammation array. Now we have a whole number of different samples. So these are patients, and they're very different than the homogeneous mouse populations that I'm used to using, where everything is, genetically identical and you can expect very similar results. I was really surprised at the amount of diversity that we see between different samples, and we have not run all of the samples on both cards. So that being said, the IL-1 beta may have been decreased, but didn't make the twofold cutoff on when we did this particular analysis. So we are planning on running everything. This really, we're only a few months into this project. We just started in the end of November, and then we're shut down at Brown up until Monday. So we're really far behind, but I wanted to show you the preliminary data that we have so far. So hopefully when we get all of the samples run, that genes that would be consistent between those two cards will show up consistently.
And do you have any information on amyloid PET or tau PET scans on any of the subjects who provided saliva samples?
Yes, we do. And Lori is going to get me that information. I have not received it yet, but they have a subset, not on all of them. They have a subset that have had PET scans and had their CSF analyzed. And I think, once I get that information, that will be very interesting to pull those groups out and see how they compare to patients that had those tests but were normal, and then of course the rest of our normal patients, and see if they show any skewing more towards what we're seeing when the patients that have a clinical dementia score.
Okay, great. Very good. So I think that's it. And we thank you very, very much, Jill. Great presentation, and fitting one to end 2 half days of our theme of aging research in Rhode Island. Fantastic. So this ends day 2 of our 2020 Rhode Island IDeA Symposium. I want to thank all of the presenters for wonderful work that you presented. It was very informative and displayed a wide range of very exciting scientific research. I also want to thank our colleagues, attendees from the National Institute of Aging and the National Institute of General Medical Science who are able to join us today. We will be surveying all of the participants in our symposium in the next few days. Please provide us with input on how we can improve this session, and also be aware that full recordings of the symposium will be available soon. So with that, we'll close the proceedings, and thank you very much for the presentations, the great questions, and for your kind attention. Have a great day.